Hey guys, what's up? This is Stephanie. Welcome back to my channel. So in the video today, I'm going to be going over dermatology. So I'm going to be going over the dermatology block for the Physician Assistant National Certification Exam, or the PANCE. So I hope this video is helpful, not only for those of you who are studying for your PANCE, but also for those of you who are currently in your didactic year. This will definitely help you a lot for your clinical medicine exams, even some of your exams for pharmacology. So I hope this video is helpful. If there are any mistakes, please comment below. That way I can add it in the description. And I apologize if I make any mistakes, but please feel free to correct me. In addition to that, if you have any cool mnemonics to learn certain medications that you learned when you were studying for the PANCE or in PA school in general, for diseases even, make sure you comment below. You can also help other students. So why don't we go into dermatology? So why don't we start with bacterial infectious diseases? So let's start with folliculitis. So folliculitis is a superficial bacterial infection of the hair follicles. If it's multiple, then we think about our carbuncle. Some of the common bacteria that is associated with folliculitis, we think about Staph aureus. Like Staph aureus is found all over the skin. If a patient has a history of being in any type of water, for example, swimming pools, hot tubs, and we're thinking about Pseudomonas. And if there's any pustules that are found in the groin area, we're thinking about candidiasis, but usually the most common one is going to be Staph aureus. So where's folliculitis? Where would we see it? How is the patient going to present? So whenever we think about men, right, that shave, they get those inflamed hair follicles. So usually it's going to be any area that is hairy after shaving, right? Usually in the face when we think about men, it can happen even in the legs. And what you're going to see on your physical exam is going to be those small raised erythematous, very, very itchy pustules that are going to be less than 5 centimeters, so they're not going to be very big. You're going to see crust, pus, and tenderness, and they're going to be very, very itchy. And the thing about these is that if they get very infected, they can actually go into become a furuncle or even an abscess. So treatment with these is just cleaning them with antibacterial soap, right? If it's a superficial pustule, usually these tend to go away by themselves or drain by themselves, so you really don't have to do anything. If you do want to give the patient medications, you can do something like localized mupirocin, which is going to be a bacterial ointment, right? You can also give them penicillin, dicoxicillin, amoxicillin if needed for 7 to 10 days. Other medication we can give is minocycline, Bactrim, right? If it's really, really bad, like and they have a very severe case of folliculitis, then we can give oral antibiotics. But once again, usually no treatment is needed. If we do want to give treatment for these patients, then we'll just give them something that covers Staph aureus, and Staph aureus is going to be the most common cause of this. So the next one is going to be abscess. And once again, the most common bacteria associated with an abscess is going to be what? Staph aureus. Why? Because it's found all over the skin. So this is going to be a collection of pus within the dermis and the deeper skin tissues. So if you think about your anatomy, right, you have your epidermis, you have your dermis, and then you have your subcutaneous tissue, you have your muscle, etc. So the deeper you get, the worse the infection is. So this only involves the dermis and the deeper skin tissues. So this patient is going to be presenting with a fluctuant, and this is actually the key word for this one, is that you're going to see usually a fluctuant mass. So it's going to be fluctuant, right? Anything that's fluctuant, I think about an abscess anywhere in the body, it's going to be very painful. It's going to be red, tender, and sometimes you may see a pustule also, and usually you'll see that it's surrounded by a rim of erythematous edema, and sometimes it can drain also, and it's going to be very warm. So treatment for these patients, since it's fluctuant, like we said, abscess, we're going to do an IND, so incision and drainage. If it's severe or if it's extensive, or if the patient, for example, is diabetic, like if they're immunosuppressed, or if they have any type of comorbidities, then we can add antibiotics. So what are some of the medications that we're going to add? So of course, we're going to protect against what? Staph aureus. So we're going to try to use medications that cover Staph aureus. So things like clindamycin, Bactrim. If the patient is hospitalized, then we want to make sure that we cover for Staph and MRSA. So with these patients, we'll do something like vancomycin. You can do linezolid and also daptomycin. And if there's any type of pus that we see, we want to make sure that we culture these patients. If it's a furuncle, right? For these patients, we just do warm compresses for these patients. If it's larger, we try to treat them with an abscess. And then just what's a prophylactic treatment for these patients for an abscess from preventing to get an abscess? So just washing the area with antibacterial soap and benzoyl peroxide can actually prevent a patient from getting an abscess. The next one's going to be cellulitis. So once again, when we think about these infections, we think about what layer of the skin is being involved. Is it affecting that epidermis? Is it affecting that dermis, the subcutaneous muscle, subcutaneous tissue and muscle? And cellulitis, where does it affect? So this cellulitis, and why we're very aggressive about treating this, is that it involves the deeper dermis and the subcutaneous tissue. So it goes really, really deep. So it goes through that epidermis, it goes through that dermis, and then it goes through that subcutaneous tissue. So it's an infection of the dermis because there's some type of trauma to the skin where bacteria is able to get in. So usually with these patients, we think about any patient that had trauma, right? For example, I was in the burn center, and that was a lot of things that we saw. We saw a lot of cellulitis in these patients because why? They have burns, right? They have trauma to their skin areas, or sometimes they burned off that epidermis, or they burned off part of their dermis. Another cause would be ulcers, right? Also maceration between the toes, fungal infections like tinea pedis, and some of the common pathogens is going to be, of course, Staph aureus, right? Especially in your open wounds, and that's what we covered for usually in our inpatients at the hospital. We covered for Staph and MRSA since they have an open wound. Another one is going to be group A strep. If it's an animal bite, we're thinking about which one. This is something that's very commonly tested in your emergency medicine end of rotation exam and also your PANCE. So we're thinking about the bug that is associated with animal bites, Pasteurella multiseda. I apologize if I missaid that. So once again, Pasteurella. If it's a human bite, we're thinking about Eikenella. If it's a very purulent cellulitis, or if the patient has a history of IV drug use, then we're thinking about MRSA. So once again, risk factor is going to be any type of trauma to that area, whether it's a skin infection or burn, like we said, or just even scratching that area. So this patient is going to be presenting with a non-fluctuant tender plaque. It's going to be spreading, it's going to be erythematous, and it's very commonly found in the lower leg. It can be found, of course, in the arm area if the patient is an IV drug user. You're also going to see streaks of lymphangitis, skin erythema, edema, warmth, fever, chills. And the thing about cellulitis and how you can differentiate cellulitis from erysipelas is that cellulitis is very poorly differentiated versus erysipelas. Usually with these patients, there is going to be differentiation. And that's how you differentiate erysipelas from cellulitis, because they can look very, very similar. But with erysipelas, you're going to see those borders. It's going to be very differentiated. Versus cellulitis, you won't be able to differentiate it. And the treatment for these patients is we want to make sure that we treat these patients early, right? Because if we don't treat cellulitis, especially since a lot of these patients are immunocompromised, I think about my burn patients, it can lead to septic shock, even death. So if it's a non-purulent cellulitis and we're treating the patient as an outpatient, we're covering for group A strep, right? Then we can give something like cephalexin. Usually bug bites can also cause cellulitis. If it's an IV drug user, then we're covering for MRSA. And what are some of your medications that you can prescribe for like oral antibiotics for MRSA? Things like clindamycin. If it's a purulent cellulitis, then in this patients, we want to cover for both MRSA and strep, and we're going to do clindamycin. And this is also going to help cover for, once again, MRSA. And then, of course, we want to make sure that we culture it. If it's fluctuant, then we want to make sure that we IND it. Another thing that we did a lot in the hospital is that we would do a Sharpie, right? Because you want to monitor its progression to see how far along it's going. Is the treatment you're giving the patient good or not? Or do you need to change maybe to another medication with these patients? And also the medication that the patient's on, is it helping the patient at all with the treatment? So next one's going to be erysipelas. This is going to be more superficial in comparison to cellulitis. Remember that we said cellulitis involves the epidermis, the dermis, and it even goes into the subcutaneous tissue. Well, erysipelas does not. So erysipelas is just superficial, right? It has marked dermal lymphatic involvement, and it only involves the upper dermis. So it only involves that upper dermis. The most common bacteria is going to be group A strep, and then also Staph aureus. By far the most common one is going to be your group A strep. This patient is going to be presenting with a pain, bright erythema, but the thing about this one, it's going to be more raised, and you'll see also with these patients edema. And the thing about this one is that this one's actually also on the face. So remember when we were thinking about cellulitis, usually it's on the lower extremity. This one's on the face also. So erysipelas can be on the face and also on the lower extremities, but also just take that in consideration that it can be on the face. This patient is going to be presenting with fever, also headaches, and treatment, just monitor it, right? Ensure that we are covering for strep, since we said group A strep is going to be the most common cause. So things like penicillin V, amoxicillin, clindamycin, or macrolide can be the best treatment for erysipelas because we're covering for that group A strep. The next one's going to be impetigo. So impetigo, very commonly found in children, especially between the ages of 2 to 5. This one is very, very contagious. And this is usually a superficial infection, bacterial infection of the skin. And with these patients, it's going to be, once again, any type of trauma to the epidermis, right? Also, if the patient has any pre-existing like eczema, wounds, and usually the bacteria is involved in impetigo is going to be Staphylococcus aureus. So with these patients, how are they going to appear? So usually it's that honey-crusted appearance. That's like the buzzword for this one. So it'll start with like papules. It's going to be surrounded by erythema. Then it's going to progress to form pustules that are going to enlarge. And then it's going to form like a thick adherent crust. And that's where you get this honey-crusted appearance. The most common site is going to be in the nares and in the mouth. But I've also seen it in the diaper area also and in the buttocks on question stems, which have confused me. So keep that also in mind. And this one's very contagious and it's very itchy, so the child's going to be constantly scratching themselves and they're going to be auto-inoculating themselves. And the thing about impetigo is that there's also a bullous form of impetigo, and bullous form we'll usually see flaccid bulla with clear yellow fluid. It's going to be purulent, and whenever it ruptures, it's going to leave that thick brown crust on the face extremities and also the diaper area. Treatment for this is, for impetigo in general, if it's localized, which is more commonly you're going to see it around the nose, right, around the mouth, you can just do something like topical mupirocin. If it's extensive, and usually how it'll present on the question stems is that it won't only be on the face, but it'll also be like on the buttocks area or on the arms or anywhere else. Then with these patients, they get oral antibiotics. So you'll get things like dicloxacillin, cephalexin, erythromycin, clindamycin, or augmentin. The next one's going to be eczema. This is going to be just impetigo that progresses. So it's going to be impetigo that did not get treated. So it's going to be untreated impetigo. This is going to be an ulcerative lesion that extends through the epidermis and into the dermis. Some of the etiologies for this is going to be staphylococcus and strep. In patients that are very, very sick, we're thinking about Pseudomonas aeruginosa. And usually this is very commonly found in patients that, for example, areas that are occluded. So for example, soldiers that are wearing boots on for a very, very long time, right? They're outside. Homeless people. And what you're going to see is going to be that punched out ulcer, and that's what's kind of going to give it away. So it's going to be a punched out ulcer with a yellow crust that's surrounded by raised margins. So once again, that's punched out ulcer with yellow crust. You're also going to see infarcted center with an erythematous halo. It's going to be very painful. It's going to be tender. And usually with these patients, we're going to treat them like with oral antibiotics, right? The thing about eczema is that this one scars. Okay? And some of the complications for this is that since it's associated with group A strep, the patient can develop scarlet fever or even your post-streptococcal glomerulonephritis. So group A beta hemolytic post-streptococcal glomerulonephritis. So next, let's go into the next one. It's going to be infections of the nail. So let's go into acute paronychia. So you have your acute paronychia and you have your chronic paronychia. It's going to depend, of course, on how the patient presents, right? So acute paronychia, it's going to be infection of the lateral or proximal nail fold. And it's associated with what? Once again, some type of trauma or break in that epidermis. The most common bacteria associated with paronychia is going to be staph. It seems like staph with dermatology, right? Staph with dermatology for everything. Why? Because it's found everywhere. It's found all over our skin. So Staphylococcus aureus and group A strep. And some of the risk factors is going to be a patient that just likes to bite their thumbs, their fingers a lot. They suck on their thumbs, or like in fact auto-inoculate themselves with their oral flora, picking at a hangnail. I know a lot of us do that a lot. Ingrown toenail, also very commonly found in your diabetics also, and also even manicuring is associated with acute paronychia. So this patient is going to be presenting with like a swelling. It's going to be erythematous, throbbing pain, and sometimes it can even form into an abscess. It can even go deeper and form a phelon. And usually with these patients, if the patient does have an abscess, then we're going to make sure that we IND it and then we culture it. If the patient is immunosuppressed, like they're diabetic, since this is very commonly found in your diabetics, or if it's just a very severe case of paronychia, then usually with these patients, we'll give them oral antibiotics. If there's no abscess, which is commonly the cause, usually these patients get topical antibiotics, right? If it's a severe, oral antibiotics, like we said. And then usually for those nail biters where they're putting their hands in their mouth a lot, remember when we were talking about human bites, we talk about Eikenella, right? So same with your nail biters. So Eikenella, we're thinking about that bacteria, and usually augmentin is going to be the treatment for those nail biters. Chronic paronychia, it's going to be that chronic inflammatory dermatosis that is involving the nail folds in the matrix. It's associated with damage to the cuticle. So some of the causes of this is just repeated exposures to the irritants and allergens. And what happens is that you get some type of colonization of fungi and bacteria. Some of the very common things that are associated with the chronic paronychia: Candida, Pseudomonas, and Staph aureus. Risk factors is going to be adult women. Also, what is the occupation of the patient? Fishermen, housewives, individuals that handle a lot of food, so your food handlers, bartenders, house cleaners. Also, if they have any type of dermatosis problem, right, like or irritant contact dermatitis, allergic contact dermatitis. And how is this patient going to present? So usually it's going to involve the first, second, and third fingers of the dominant hand. It's going to involve that proximal or lateral nail fold that's going to be swollen. It's going to be red. The cuticle is going to be absent, and that's a keyword for this one. The nail plate can also be discolored. You'll see nail dystrophy, and then once again, no cuticle. Treatment for this is, of course, if the patient, for example, gets this because of their occupation, just make sure that you're protecting your hands. So gloves, keeping them dry. But just medication-wise, you can do topical glucocorticoids. The next one's going to be hidradenitis suppurata. This is going to be a chronic suppurative cicatricial disease of the apocrine gland bearing skin. And with these patients, more commonly found in your females and males, usually they're going to have some type of genetic. So it'll say, oh yeah, my mom had this. And that's very associated with this. And some of the factors that can predispose a patient to developing hidradenitis suppurativa is going to be obesity, smoking. Also, if they have a genetic predisposition to acne, which is really, really interesting. Secondary bacterial infections. And some of the areas that are going to be found is going to be like in females, the axilla, the breasts, the groin area. Usually the anal genital region is usually associated with males, the back, the butt, and it usually presents bilaterally. So this patient is going to be presenting with pain and marked point tenderness related to the abscess. You'll see open comedones, pericomedones. You'll see tender red inflammatory nodules and abscesses, tender sinus tracts. And then the keyword for this one's going to be those bridge scars, right? That area is going to be very, very hypertrophic. You might even see lymphedema. And treatment usually for these patients is going to be glucocorticoids that are done intralesionally, followed by incision and drainage. You're also going to give them oral antibiotics, so things like erythromycin, tetracycline, minocycline, clindamycin. And usually if the patient is having a lot of pain and inflammation, then we can give them something like prednisone. If it's an acute abscess, we're going to do incision and drainage, right, for these patients. If it's extensive, then we need to go in there and completely excise the area. So we'll have, for example, if it's in the axilla, we're going to have to go in there and completely excise the axilla area. So that's going to be hidradenitis suppurativa, once again, very commonly found in females, and look for that genetic history in the question stem, like my mom had it, or one of my other sisters has it, etc. So the next one's going to be pilonidal disease. This is going to be an infection of the skin and subcutaneous tissue at or near the upper part of the natal cleft or natal cleft of the buttocks. It can be acute or chronic, and this one's usually acquired, more commonly found in males. And some of the risk factors is going to be obesity, any type of trauma to that area. If a patient just has a sedentary lifestyle also, if they're sitting for a very long time, if they have a family history. And this patient's going to be presenting with, usually you'll see primary pores that are midline of the natal cleft. You'll see a painless sinus opening lateral to the cleft. There's going to be a tender mass. You'll see drainage and hair protruding from the sinus. And with an acute infection, usually you'll see sudden onset of pain to the intergluteal region while sitting or performing activities that stretch the skin overlying the natal cleft. You'll see intermittent swelling, mucoid, purulent blood drainage. If it's a chronic pilonidal disease, then usually it's going to be recurrent, right, or persistent drainage, and this is very painful. So diagnosis is clinical. Treatment usually for these patients is, if it's an acute case of pilonidal disease, we do incision and drainage. We'll debride all the visible hair. And if it's chronic, we're going to do surgical excision of all sinus tracts. And that's usually how they're going to present on the question stem. It's going to be your chronic. So usually these patients need surgical excision of all the sinus tracts. So the next one's going to be necrotizing fasciitis or neck fash. It's your flesh-eating bacteria. This is a surgical emergency. Why? Because this has a very high mortality rate. I saw a lot of this during my rotation during the burn center, and we got a lot of patients with a neck fash that were sent to us. And like I said, this is a surgical and medical emergency. So this patient's going to be presenting with symptoms of sepsis, fever, severe pain, indurated edema, bulla, cyanosis, skin, hyposthesia. So hyposthesia just means that it's very, very painful to them. Foul smelling exudates is what you're going to see on your physical exam, black eschar. And the thing about this one is that it goes really deep into the tissue, right? So it can involve the skin, it can go deep into the subcutaneous tissue, it'll even go deep into the fascia, and it can even get into the muscle. And another way that I've seen this question asked is that you'll see that crinkling, like you'll put pressure on it, and you can that's how it's going to feel. So with these patients, they go to surgery. So you get widespread debridement. You're going to debride that entire area. And sometimes, if it's like on extremities, like I've seen it on toes and fingers, they have to go in there and amputate it because that finger or that toe is just not viable. Very commonly associated with your patients that are immunosuppressed, like your diabetics. It's one of the patient populations that I saw it a lot. So you're going to do widespread debridement and then spectrum antibiotics also. So you're going to cover for necrotizing fasciitis. So now we went into our bacterial infections. Let's go into our viral infections for dermatology. So let's go with the erythema infectiosum. This is a rash, and what happens with this rash is that it appears abruptly and it affects a lot of areas in the skin. This patient can also present with eruptions on the mucous membrane. And then whenever I think about erythema infectiosum, very commonly found in your children, especially your children between the ages of 4 to 10, but it can also occur in adults. So the most common virus associated with erythema infectiosum is going to be parvovirus B19. So make sure that you know this, parvovirus B19. Also, parvovirus B19, we think about sickle cell disease. So you can actually put patients into sickle cell crisis, right, for parvovirus B19. It's another way I've seen it asked. But parvovirus B19 is going to be associated with erythema infectiosum. And the thing about parvovirus B19 is that it's transmitted through respiratory tract excretions and also from mommy to baby. And usually with these patients, how are they going to present? So they're going to present with fever. It's going to be a low fever. They're going to have those viral symptoms, right? Malaise, headache, pruritus, coryza, myalgias, joint pain, especially like if you think about your older patients. And then they're going to be presenting with that exanthem. So exanthem is outside the body. Enanthem is going to be inside the body. So exanthem, we're thinking about outside the body, and this is the first symptom and sign that the patient's going to be presenting with. So it's going to be those bright red cheeks, right? So it looks like that baby or that child got slapped. Sorry, it's like boom, because it's gonna be those bright red cheeks. They got slapped by parvovirus. So they got slapped by parvovirus. So it's gonna be those slapped cheeks, and usually that rash is gonna go away over 1 to 4 days. And it's going to be erythematous. And then you'll see that lace-like eruption on the trunks and extremities. So erythema infectiosa is also known as your 5th disease, right? So with these patients, it's usually a clinical diagnosis. The preferred test is going to be your specific IgM antibody, which is going to be positive. And treatment for this is just supportive, right? Because it's a viral infection. So it's supportive. It tends to go away after 5 to 10 days with these patients. And just educate the patient on preventing erythema infectiosum. So wash your hands, right? Avoid sharing eating utensils. Next one's going to be measles, also known as your rubeola. So you have your German measles, which is rubella, and then you have your regular measles, which is going to be rubeola. This one's measles or rubeola. Just make sure you know that, because sometimes you'll see on the question stems and you know it's measles, but they'll put rubella and then they'll put rubeola. And that's how they try to trick you. So rubeola is going to be measles. German measles is going to be your rubella. So with these patients, the incubation period is going to be 8 to 12 days. This one's transmitted through respiratory droplets. And we've been seeing the cases increase in the past few months, right? In the past few years, just in general, because of everything that's going on with vaccination. Not a lot of people are getting vaccinated. So this is actually a very preventable viral infectious disease, and it can actually even be eliminated, and that would be only if everyone in the world got vaccinated, right? But unfortunately that is not occurring nowadays. So measles, rubeola, very commonly found in your unvaccinated children, right? It's contagious from 1 to 2 days, and usually with these patients you're going to be presenting with the prodrome, which is where they present with your fever, malaise, conjunctivitis, cough, and coryza. So that's going to be those 3 C's, right? Conjunctivitis, cough, and coryza. You can also include maybe like the 4th one, but it's the K, complex spots. That's usually what I look for in the question sum. Cough, conjunctivitis, coryza, and then your complex spots. So the prodrome is going to have those 3 C's, cough, coryza, and conjunctivitis, fever, those body aches. And then you have your exanthem, which is going to occur where? Once again, that outside the body. So you're going to see an erythematous macular papules that are going to start on the face, and then they're going to spread down. And that's a key for all these viral infections, is just reading to see where it starts. Is it starting in the trunk and starting in the trunk and it's spreading outwards? Or is it starting in the head, like cephalic, and then just spreading down? So with your your measles, right? This one, like we said, it's going to be presenting starting where? So this one's going to be starting in the head, and then it's going to be going down. So it's going to start in the face and then spread down. And then if you blanch the lesions, they're going to blanch with pressure. And usually by the 3rd day, the whole body is going to be involved. And then you have your enanthem, which is going to be inside the body. And this is going to be those complex spots, right, that you see inside the buccal mucosa. So it's going to be those multiple blue-gray spots on the mouth, right? And then diagnosis for this is going to be clinical. We're going to confirm it with serology. And it's really important that we report these cases to the State Department and local department without waiting on the test results, because this is a very, very transmissible disease and it can kill other people, especially your immunocompromised patients. So diagnosis is going to be a clinical diagnosis, like we said. And if you do serology, which is how you're going to confirm it, you're going to see you're going to do your anti-measles, IgM and IgG, which are going to be positive. You can also look for the measles RNA, right? So look for the measles virus. And usually, since this is a viral infection, right, it's going to be self-limited. So it'll go away within 10 to 12 days, and just supportive care, right? Fluids. There's been studies that say vitamin A is very helpful for patients with measles. And how do we prevent this? Just immunization, right? Your MMR. Measles, mumps, and rubellas. So MMRs that children get. And why is it important that we treat measles? Because there's so many complications that are associated with it. Pneumonia, otitis media, especially children that are under the age of 5, they're at very high risk for death. In addition to that, measles will go everywhere. So The patient can get neurological problems. So the patient can get meningitis, vision loss, parencephalitis. So the next one's going to be your hand, foot, mouth disease. So hand, foot, mouth disease very commonly occurs during like late summer, early fall. And what they really like to test is what virus causes it. And that's just for all of these dermatology. They like to test you on what's the bacteria associated, what's the virus. So this one's going to be Coxsackie virus. And Coxsackie virus, another thing that we keep in mind, right? It's associated with a lot of things. It's associated with myocarditis. It's associated with herp angina. But Coxsackie virus is associated with hand, foot, mouth disease. Why is it called hand, foot, mouth disease? Because that's where it's going to present, right? It's going to present, and it's going to start in the mouth, and then it's going to go to the palms of the hands, and then it's going to go to the soles of the feet. Even though it can involve other areas, those are the common areas you're going to see on your exam. So this patient is going to be presenting with your prodrome, once again, your exanthem, and then enanthem. So your prodrome is going to be your fever, sore throat, malaise, joint pain. That exanthem, which is going to be outside the body, bright pink macules or papules, painful vesicles with erythematous halos, erosions with erythema, and then that enanthem is going to be those canker sores, so those erythematous erosions that you'll see, right, in the mouth. Diagnosis is going to be a clinical diagnosis, and treatment, it's a viral disease, so the patient's going to get better by themselves. So just make sure that you are drinking a lot of water, give anything for fever and pain relief. Next one's going to be herpes simplex virus with these patients. So herpes simplex virus, you have 1 and 2, and you really need to know the difference between 1 and 2. It'll help you out to see how they are transmitted. Herpes simplex virus 1, and how I think about it, it's 1. So it's going to be presenting anywhere in the mouth. It can even present in the nose. Usually we think about the ones that present on the lips also. Herpes simplex virus 2, this one's going to present usually in the genital area, so the vagina, the penis, the buttocks, the thighs, and how they really like to describe this on your question stems is going to be that rose petal on that drop on a rose petal, right? Or that vesicle on an erythematous base, right? So it's a clear vesicle, erythematous base. You can also get them pustular, so sometimes if they are pustular, usually white or yellow. And then with these patients, there's different types of herpes simplex, like kind of like subtypes. So you have your herpetic whitlow. This is where it presents on the fingers. They're usually going to be multiple red borders, pustular, and associated with oral herpes simplex virus, very commonly found in, like, for example, dentists, right? Since they're putting their fingers a lot in people's mouths. You also have blistering dactylitis. This is usually a single bulla. It's associated with strep. You culture and aspirate this. And how we diagnose herpes simplex virus, we're going to do a zinc smear. Viral culture also, you can do a PCR for these patients. And treatment's going to be just any of your antivirals. So we think about acyclovir, right? And then just first line, though, in general, it's going to be conservative because that's how the PANCE is. That's how your EORs are. First line's always going to be any type of conservative treatment. So things like cold compresses, lubricants, topical analgesics, oral analgesics. But once again, acyclovir is going to be like your medication that you're going to prescribe for these patients. So next one's going to be your varicella zoster, also known as your chicken pox, right? This is an infection that's caused by what? Varicella zoster virus. It's transmitted through respiratory droplets, through fluids in the vesicles also, and it's very contagious, especially 2 days before the rash begins. Until the rash is gone is where the patient is contagious. So how is this patient going to present? So you're usually going to see crops of pruritic vesicles to pustules to crusts. So once again, usually it's going to say crops. So it's going to be crops of pruritic vesicles to pustules to crust. And the thing about these is that they can actually scar. My mom actually has some on her face that's scarred that she kept picking at when she was younger. And these can involve the face. They're going to involve also the trunk, right? And they can involve also the extremities. Diagnosis is going to be clinical diagnosis, and treatments, it's a virus, so it's going to be supportive treatment, right? We can give the patient antihistamines that's going to help with the itching, and usually the crusted lesions are going to heal in 1 to 3 weeks. The thing about varicella zoster virus is that there's the complications associated with it is that it can cause encephalitis. Also, if the patient's constantly scratching at it, right, they can infect it and it can cause a bacterial infection for these patients. The next one's going to be herpes zoster. This is also known as your shingles, right? And this is usually due to an eruption of a latent varicella zoster virus. So they got infected with the varicella zoster virus, it stayed dormant in their body, and then it just came back up, so it erupted. And this one passes from the skin lesions to the ganglia. Very commonly found in adults, but it can also happen in children. And usually the infection comes out, right, or it's triggered by immunosuppression. So the patient has some type of immunosuppression, trauma, tumor, irradiation. Remember, I had once a 21-year-old girl that came in with herpes zoster, and when I went to go see her, my ER doctor told me, think about it critically. What else do we have to investigate? This is not very commonly found in patients at her age. Usually we think about older patients. So she probably had some type of immunosuppression going on. So also keep that in the back of your mind. Very commonly found in your older adults, but if you do find it in a child or someone that's young, you want to think about maybe some type of immunosuppression going on. So how is this patient going to present? They're going to have a dermatomal eruption on one side of the body. Usually, once again, you're going to see those grouped vesicles on an erythematous base, or that rose petal, right? Vesicle on a rose petal. Very commonly found on the trunk, and this is very painful. The patient's going to say that there's a lot of pain, there's burning, they have tenderness, also like paresthesias also is that what they're going to present with. They're going to present with flu-like symptoms. So they're going to have that general malaise, right? Weakness. You can sometimes also find lymphadenopathy, but it's not always present. And the thing about this one is that it's always going to present in a dermatomal pattern. So once again, it's going to be presenting in that dermatomal pattern. And that's how you can tell that this one is shingles. So this is a virus. So treatment for this is just going to be conservative treatment, right? And like I said, the PANCE is all about conservative. So that's usually first line, unless they specifically ask you what pharmaceutical therapy do they require. So usually it's going to be bed rest, pain management. So then that's one of the key ones is pain management. Now you can give them an antiviral like valcyclovir, acyclovir. For these patients, usually the common one's going to be something like acyclovir, right? But the thing that you do need to educate patients about this is that with, for example, your antivirals, they're not going to treat it. They're just going to slow the progression. So once again, it's not going to fully treat the patient. It's just going to reduce their viral load, right? Because that's what most of the antivirals do. And how can a patient prevent herpes zoster? So one of the big things is going to be ensuring that the patient gets vaccinated, right? That's going to decrease the recurrences. And with these patients, usually the vaccination is going to be a live attenuated virus vaccine for your herpes zoster. Now, if these patients present with post-herpetic neuralgia, then some of the medications we can give to them can be something like gabapentin, right? Pregabalin, your tricyclic antidepressants like doxepin can help with that. And usually when we think about post-herpetic neuralgia, it's going to be a patient that's presenting with severe stabbing or burning pain. They're going to be complaining of dysesthesia, pain for months or years. And this is very commonly found in your older patients or your elderly. Some of the other complications of herpes zoster is that it can involve the eyes. So we want to make sure in these patients we also look inside their eyes, right? Because what can happen is that they can get ophthalmic zoster. This is where the side and the tip of the nose are involved. So this patient is going to be presenting with headaches, right? Hemiplegia. And it can also cause meningoencephalitis, Ramsay-Hunt syndrome. So it's really important that with these patients, we ensure that if there's any new symptoms that the patient's presenting with, that we do further follow up with them and further investigate these. The next one's going to be molluscum contagiosum. So this is a benign, it's usually an asymptomatic viral infection, and this one has no systemic manifestation. So it's a viral infection of the skin, and what they really like to test for this one is the virus that causes it. So you have to make sure that you know that the pox virus is what causes molluscum contagiosum. So pox virus causes this. And what happens is that this virus colonizes the epidermis and that hair follicles. Remember when we were thinking about the layers of the skin, it's going to be that epidermis. Very commonly found in your children, also in your sexually active adults, and it's usually passed through contact through skin, right? Fomites, autoinoculation, especially in your children, like they're constantly scratching and touching themselves. And in regards to like your older patients, also very commonly found in your wrestlers. So how is this going to present? So usually it'll be about 2 to 20 discrete 5 mm diameter, flesh-colored, pearly dome-shaped papules with central umbilication and dimple. So once again, the keyword for this one's going to be your flesh-colored, pearly, dome-shaped papules that have central umbilication. That's going to be the keyword, and that's what would kind of help me in regards to the question. So dome-shaped papules, flesh-colored, pearly, central umbilicated, and they can be found on the face, the trunk, the extremities, right? And one of the ones that they really like to test also is the boat sign, so the BOTE, which is beginning of the end, that's what it stands for. So usually in the question, it's going to be a patient that comes in, right? They have this tenderness, this crusting, and usually the keyword is going to be that crusting, erythema, inflammatory halo, and that just means that the patient's getting better, right? So that's why it's called boat sign, BOTE, beginning of the end. So the molluscum contagiosum is ending, or it's getting better, right? It's resolving. So once again, flesh-colored, pearly, dome-shaped papules, central umbilication, molluscum contagiosum, pox virus. And treatment for this is going to be self-limited. It's going to go away by itself, right? So there's usually no treatment. Sometimes it can stay up to 6 months, but there's usually no treatment for these patients. If needed, you can do something like curettage, cryotherapy, but it's going to be mostly cosmetic than anything. And of course, we don't do this in children, right? Electrodesiccation, very painful. So you don't really do these in children. So the next one's going to be your verrucae or your warts, very commonly found in males and females. So how is this transmitted? So it's transmitted through skin-to-skin contact, right? Any type of trauma to the corneum, contaminated surfaces, also if there's any defects on the host defense, right? So the most common areas are going to be definitely on the fingers. You can also get it on the dorsum of the hands, the knees, the elbows. And how is this patient going to present? What are you going to see in your physical exam? So you're going to see these hyperkeratotic, exophytic, growing outward dome-shaped papules or nodules that are firm. They're going to be about 1 to 10 millimeters. And they're going to be clefted with vegetation. That's usually the buzzword with this one, is that the buzzword is going to be exophytic, so it's going to be growing outwards, right? You're going to see some vegetations. It's going to be hyperkeratotic. Another buzzword for this one, that it's going to be punctate black, and usually the dots that you see, it's usually thrombosed capillary. So if you see anything on the question stems that says that it's hyperkeratotic, there's vegetations, and it's punctate black, or it has like a black dot, think about your verrucous warts with these patients. So, flat warts. So there's different types of warts. There's a flat warts, there's a palmoplantar warts. The flat warts are usually skin colored. They're like brown and pink. They're smooth. They're slightly elevated, and they're usually the flat top papules, right? They're usually round and oval. They're going to be sharply defined, and these are the ones that are usually found on the dorsum of the hands, the arms, the face, and the chins. And then we also have the palmoplantar warts. These are going to be thicker. They're going to be endophytic papules, where they're going to be depressed deeply into the skin of the sole. You'll also see mosaic warts, and usually these can accumulate thick callus over warts. Sometimes they're very painful also whenever the patient is walking. So once again, this is going to be in the plantar portion of the feet, right? Diagnosis is usually clinical diagnosis. Treatment is observation. Most of these tend to go away by themselves, but the first line medication treatment is going to be your salicylic acid, right? So you're just going to go in there, put some salicylic acid, and it'll usually go away. So let's go into our next topic, which is going to be fungal, parasitic, and bites. So the first one's going to be your Candida. So Candida intertrigo cutaneous. So in regards to Candida, right, there's different areas that it can present. You think about diapercandidiasis, but this one's going to be your Candida intertrigo. This is going to be an inflammation of the large skin folds with these patients, and some of the causes or the areas we're going to see it very commonly is going to be in your gluteal cleft, any type of inguinal crease. Sometimes there'll be inflammatory folds, right? Perineal and folds under the pannus, like the abdominal area, like especially in patients that are obese, you'll flip up the pannus and then you can see the cutaneous infection with candidiasis. And on your physical exam, you're going to see sharply demarcated, red, eroded patches that are very, very itchy. And the keyword for this one's going to be satellite macules. That's usually how it's going to present on your exam. It's going to be your salivate macules, papillars, or pustules around erythema and fold. Usually it's going to be in areas that are moist, right? Moist occluded areas. And that's why just fungus in general, right, really likes those moist areas. And that's why in very commonly obese patients, PANCE area, you know, in the armpits, areas that are very prone to getting moist is a perfect environment for Candida. So diagnosis for these patients is going to be with a KOH. We're going to see scales. You can also do a fungal culture with these patients, but usually KOH is a good one for the exam. And treatment's just going to be with topical antifungals, right? You can do something like nystatin. You can do any of your imidazoles, and then topical anti-inflammatories like low-strength corticosteroids, since it's going to be very painful for the patients. It's going to be very burning, very itchy for these patients. And a best way to prevent these is just to make sure that you educate the patient to keep that area dry, clean that area, like the PANCE area, any area that's very sweaty. If the patient's obese, educate them on weight loss. Educate the patient on wearing loose clothing that's made out of cotton. So the next one's going to be diaper candidiasis. This is the one that you very commonly get during your pediatrics and rotation exams, right? You see this a lot during pediatrics rotation. So what happens, just the etiology, is that urous enzymes are present in the feces. They release ammonia, and this is what leads to disruption of the epidermis, and this is what allows entry of the Candida. And on your physical exam, what you're going to see, the keyword for this one's going to be beefy red plaques with papular and pustular margins of lesions. So once again, it's going to be those beefy red plaques with papular and pustular margins of the lesions. And the patient's going to be very irritable. They may present also with dysuria, which is going to be painful urination, which makes sense because whenever they urinate, the urine is touching that area. It's just very inflamed and angry. Dyschezia, once again, painful going number 2. So this patient's also going to have a lot of discomfort whenever you're changing diapers, so when the mommy's changing their diapers. And it can be in the general area, perineal area, can also be in the inner thighs or in the buttocks for babies, intertriginous areas also. Diagnosis is going to be clinical diagnosis. We can confirm with either microscopy or a culture for these patients. And with these patients, treatment's usually going to be with nystatin cream. We can do something like imidazole also, but this one's very irritating. Usually we'll do the nystatin cream, and you can also do hydrocortisone for these patients. If the baby is still not getting better with the treatment that you've given, right, it's refractory, then we want to make sure that we just ensure that we get more lab tests and we work up the patient for maybe any type of immunological problems, right? The next one's going to be mucosal candidiasis. This is very commonly found in the oropharynx and also in the genitalia. And in patients that are immunocompromised, then we can see the candidiasis in like the esophagus and even in the tracheobronchial tree. This is usually due to antibiotic therapy in healthy individuals and glucocorticoid therapy, whether it's topical or systemic. Also found in older patients, right, and then younger patients and any patient that's immunocompromised. We usually think about our candidiasis in patients that have, for example, HIV or AIDS. We have our oropharyngeal candidiasis. This is also known as your thrush, right? This is usually going to be found in the dorsum of the tongue, the buccal mucosa, the hard and soft palate, and pharynx that is going to be extending down to the esophagus and even the tracheobronchial tree. So on physical exam, you're going to see this white cottage cheese-like flecks on the mucosa, 1 to 2 millimeters too extensive and widespread. And usually whenever you remove them with the dry gauze, it's going to be very inflamed. You'll see erythematous mucosal surface. And that's to keep out this one and how you can differentiate it from something malignant, maybe like squamous cell carcinoma, right, is that if you try to wipe it off, it's going to come off. So once again, this one's going to come off if you wipe it off, and you're going to see like a very inflamed erythematous surface. And with these patients, we want to make sure that we treat whatever is the underlying cause, what is making this patient more prone to getting these candidal infections, right? But to treat that oropharyngeal candidiasis, we're going to do topical nystatin or clotrimazole. We can also do systemic medications like oral fluconazole, right? Any of your antifungals. And the next one's going to be onychomycosis. So onychomycosis is a fungal infection of the bed of the nail. So it's going to be in chronic fungal infection of the nail bed. So usually it's going to be a chronic infection, and usually it starts with tinea pedis, right? And this is transmitted from person to person. It can also be transmitted through fomites, most commonly found in men. And the most common type is usually going to be found in the distal subungual area. And the common, what it's going to be due to, it's going to be due to T. rubrum. So that's another thing that they really like to test. So just make sure they know this. It's going to be due to T. rubrum, trichophyton rubin. It's going to be the most common cause of onychomycosis. So make sure you know that's another thing that they like to test. So onychomycosis is some of the risk factors is going to be any patient that's immunocompromised. We see this a lot in our diabetics, right, because they're immunocompromised, and just in general, fungus really likes sugar, glucose. So diabetics have a lot of glucose. Atopic dermatitis, also in patients that wear a lot of occlusive footwear. And what you're going to see on physical exam is going to be a thickened, brittle nail, subingual debris, and you're going to see separation of the nail plate from the bed of the nail. You can also see color change of the nail. And diagnosis, we want to make sure that we do culture this before we give any type of treatment, right? Do we do this in real life? Not really. For the exam, also, we're going to do a KOH for these patients, right? And with these patients, the thing is that we don't give topicals for onychomycosis, right? We do not give topicals. The first line is going to be your terbinafine. But the thing about terbinafine is that this one is hepatotoxic. So before we do prescribe the patient terbinafine, we have to make sure that we get some LFTs on the patient just to make sure that the patient doesn't have any liver problems, because this is hepatotoxic. And while the patient is on terbinafine, we want to make sure that we monitor the patient's liver function test. So we're going to do that every 6 weeks. So once again, before we treat the patient, we have to confirm with a culture that the patient does have onychomycosis, right? We have to look for that T. rubris fungal infection. So terbinafine is going to be first line, hepatotoxic, so we have to make sure that we do LFTs for the patient every 6 months, and then make sure that we also look at their liver function before we start the medication, because if any patient has any type of liver problem, we cannot give them terbinafine. Second line is going to be anything like itraconazole or fluconazole, but by far the first line is going to be your terbinafine. So the next one's going to be tinea pedis. This is also known as your athlete's foot, right? So it's a fungal infection of the feet. The most common cause in your fungus is going to be, once again, your trichophyton rubrum. And the thing about this one is that it really likes to thrive in areas that are warm, moist environment, and those are like the shoes, especially if you individuals that get their shoes very, very wet, right? Public showers, gyms, predisposing things that make a patient more prone to getting tinea pedis, hot, humid climates, occlusive footwear, hyperhidrosis. So how is this patient going to present? So usually they're going to be asymptomatic. It's going to be very, very itchy. And sometimes they can even get a second bacterial infection, right? Because they're constantly scratching that area. And then remember when we were discussing the bacterial infections in general of the skin, it's usually due to any type of trauma to the skin. And this is one of the common ones that like we discussed, right? You're constantly scratching that area. You're traumatizing that epidermis. So these patients are very prone to getting second bacterial infections like staph, right? Which is all over our skin, group A strep. Also, you're going to see some scaling erythema. Maceration is one of the big ones. Bola, but by far, right, very, very itchy. You're going to see that maceration in between the toes. So there's different types of patterns. So it can be interdigital. That's the very common ones that we tend to see, right? And this is where there's scaling, redness, maceration, once again, in between the toes, fissuring, and it's most commonly found between the 4th and 5th toes, and it's going to be in between the toes. There's also the moccasin, also known as your ballet slipper, and the reason why it's called ballet slipper is that usually there's a sharply marginated scale, fine white, to the lateral borders of the feet. So literally there's like a margin of where it starts and it ends, and that's why this one's called a ballet slipper. And usually you're going to see with these patients also on the soles, there's going to be erythema. There can also be some papules on the margin. And usually we think about this one as 1 hand, 2 feet, right? There's also your vesicular bullous. This one's going to be grouped. So you're going to see 2 to 3 vesicles with clear fluid on the arch or instep. You're going to see erosions with ragged ring-like borders. This one's very itchy, painful, and you'll see scales on the sole. And then you have your ulcerative type, extension of interdigital tinea pedis onto the plantar and lateral foot. But by far the most common one is going to be your interdigital one. Diagnosis is going to be with the KOH, right? Culture, you can also do microscopy. If you do microscopy, that's where you're going to see that hyphae. Treatment is just going to be hygiene, right? That's the key. It's conservative. Educate your patient on the importance of keeping the area dry. Anything that's moist is very good for fungal infections. Ensuring that the patient changes their socks. They alternate shoes. Don't wear the same shoes every day. And wear open-toed shoes also. Foot powders are really good also. So first line medication is going to be your imidazole, so clotrimazole and miconazole. These are both for the candida and the dermatophytes. Second line is going to be any of your allylamines, so things like terbinafine. The next one's going to be tinea corporis. This is going to be your ringworm, right? This is going to be a fungal infection of the skin. Usually it involves the trunk and the limbs. And once again, this is due to what? T. rubrum, like we discussed. It seems like this one's very, very common. So this patient is going to be presenting with a sharply defined annular papule with central clearing. It's going to be very itchy, scaly, sharply marginated plaques. And with these patients, there's different types of variants, right? There you also think about tinea cruris, which we'll discuss in a few minutes. That's like jock itch, so this one can appear in the groin, and when it does, that's going to be your jock itch or your tinea cruris. But the key about this one is going to be those sharply defined annular papules with central clearing, very, very itchy and scaling. Diagnosis is going to be with microscopy and culture. You're going to do a KOH also. First line for these patients is going to be your imidazole, so things like clotrimizoles and miconazole. Second line is going to be any of your allylamines like terbinafine, right? And then, like, of course, if we are giving terbinafine, just make sure that we check the LFTs. The next one's going to be tinea cruris, like we discussed. This is going to be a dermatophyte infection of the groin area. Usually, that's a common area, but can also involve the inguinal area, the upper thigh, or the pubic regions. Once again, it's due to what? T. rubrum. So T. rubrum is the common cause for the majority of these, so trichophyton rubrum. And usually on physical exam, you're going to see, once again, that central clearing, scaling, well-demarcated dual red, tan, brown plaques with or without papules and pustules at margins, and it can lack scales due to scrotal occlusion. This one, with these patients, it's very, very itchy, right? And I remember I had a question once during my didactic year for this one, and it was a patient that was presenting with a very itchy rash on their inner thigh, and it had central clearing, right, scaling, and I missed it. And now that I think about it, I was so upset about it. So it can also present in the thigh, like we said. I always thought it would be very commonly found in the groin. Of course it is, but just look out for it presenting also in the thigh areas, inner thigh. The next one's going to be tinea versicolor, also known as your pityriasis versicolor. This is going to be superficial overgrowth of yeast. The most common one involved is going to be Malassezia furfur. Make sure that you know that. So remember tinea cruris, tinea corporis, it's going to be usually due to T. rubrum. Same with tinea pedis. This one, tinea versicolor, is going to be Malassezia furfur. So once again, tinea versicolor, Malassezia furfur. So usually with these patients, they're going to be suffering of a recurrence, very commonly found in your young adults. It's not contagious, so, and this one's very commonly found during the summertime, right? It's going to be a lot of patients that went to the beach, they were in the water, patients that do aerobic exercise. And on physical exam, you're going to see sharply demarcated macules or patches. Patches are going to be round, oval with fine scale. It's most commonly found in the trunk and the arms. Sometimes these patients are asymptomatic. So they just take off their shirt, right, and they notice it on their back. So what you'll see is going to be a tan salmon hypopigmented patch, or sometimes it'll say hyperpigmented patches. They're going to be asymmetric, and they can enlarge and merge to form into a large geographic area. So once again, round oval with fine scales, most common on the trunk, and that's usually what you're going to see on your physical exam and on the question stems. And the pictures are going to give you, it's going to be a patient, and it's going to be on their trunk. And what you're going to see is going to be those tan salmon hypo or hyperpigmented patches. So with these patients, we're going to do a KOH. You're going to see spaghetti and meatballs, so it'll be those round yeast and hyphae. You can also do a Wood's lamp, which is where you're going to see those blue and green scales. I've actually seen these under wood lamp and they look really cool, and it does look like blue and green scales. So treatment with this is going to be with shampoo. So you're going to do selenamine sulfide, right, or ketoconazole. So it's going to just be topical for these patients. And just to educate them that depigmentation usually persists for months after the infection has been eradicated. So the next one's going to be seborrheic dermatitis. Once again, this is due to what? Malassezia yeast. So it's going to be Malassezia yeast that just thrives on that seborrheic oil producing skin. This is very commonly found in your immunocompromised patients. So if you have a patient that comes in and they come in with this, think about working them up for immunosuppression. This is also very commonly found in your patients that have HIV, and also very commonly found in your patients that have Parkinson's, right? Also, when we think about seborrheic dermatitis, we usually think about the babies, right? The cradle cap. And with these patients, you're going to be presenting with erythematous macules, papules with that waxy, greasy yellow scales. And it's going to be usually on the scalp, but it can also be on the hairline, it can be on the eyebrows, it can be on the eyelids, it can be on the face, it can be on the nasolabial fold, right? It can also be on the external auditory canals, which I've seen it on the external auditory canals. And diagnosis is going to be a clinical diagnosis. We can do KOH. And treatment's just going to be with ketoconazole. You can also do selenium sulfide. If the patient has a flare-up, then we can do something like topical corticosteroids. But the key for this one, what they really like to test seborrheic dermatitis, is who would be the individuals, the population, right? We're thinking about our immunocompromised patients, HIV, Parkinson's, and then your infants, right? That cradle cap. And treatment, once again, is going to be your ketoconazole or your selenium sulfide. It's going to be those topical shampoos. Next one is going to be lice. So with lice, there's 3 types. We think about head louse, body louse, and then also pubic or crab louse. This is usually spread by close physical contacts or through fomites, especially when we think about that head louse, right? So sharing headbands, head to head, or even like theater seats. Usually the etiology for these patients is, of course, when we think about head lice, very commonly found in your children, less commonly found in African Americans. And what happens in regards to the pathophysiology is that usually these lice are going to hatch in 1 week, they mature in 1 week, and they feed every 4 to 6 hours on the scalp and the neck. They can live up to 30 days, and they lay about 5 to 10 eggs per day at the base of the hair. So what you're going to see on your physical exam is presence of live adult lice. You're going to see also those immature nymphs, which are going to be those baby lice, right? Viable eggs, and sometimes there's the size of the sesame seeds. The patient's going to be complaining of an itchy scalp. You can also feel the cervical lymph nodes, and there's going to be posterior cervical lymphadenopathy. You can also see oval gray or white nits. And these patients, once again, can be very prone to getting a second bacterial infection because they're constantly scratching that area. So just make sure that we look for that. And the culprits for bacteria, once again, is going to be wet staph, since we have it all over our body. Diagnosis is going to be a clinical diagnosis. We just see the lice on the bed. And we just want to make sure that we examine everyone in the household, and that we also treat family members that were sharing the same clothing, same bed with the patient, even if they don't have any lice present. So treatment for this, once again, right, the first one's going to be conservative. So, and this is one of the things they really like to test you in regards to what are you going to educate the patient, what's your patient education. So knit combing, ensuring that the patient washes their clothing, their bedding, their brushes, and their combs in hot water. So wash everything, the clothing, the bedding, everything in hot water. And with these patients, right, treatment's going to be usually with your topical therapies. And when we think about topical therapies, it's just going to be our permethrin, right? So it's going to be our permethrin, 1%. Permethrin 1% for these patients. And that's how they like to trick you. So make sure you know the percentage. Scabies is going to be permethrin 5%. Lice is going to be permethrin 1%. So once again, scabies is going to be permethrin 5%. Lice is going to be permethrin 1%. I've seen questions where they trick you and you're reading the question stem and you're like, it's permethrin. And then once you get to the answer choices. They trick you and they put permethrin also on there, and you're like, oh, I don't remember the percentage. Also, always remember that it's going to be the least, which makes sense, right? Because it only involves the head, it doesn't involve the entire body. So permethrin 1%. So the next one's going to be scabies. It's going to be due to what? Sarcoptes scabii. That's the name of the scabies. And the thing about this one is that females lay about 3 eggs per day, and they like to lay them in burrows. And that's what you're going to see on your physical exam is going to be those burrows where the females lay the eggs. And these eggs hatch in 4 days, and they can survive up to 2 days on clothing and bedding. Gross, right? So it's most commonly found in women and children, also very commonly found in immunocompromised patients. Especially immunocompromised patients will get recurrent scabies infections. Very commonly found in areas that are oversaturated, right? Congregated areas. We think about usually homeless that live in home shelters. And also this is going to be transmitted through direct contact or fomites. And on physical exam, that's where you're going to see those burrows, right? You're going to see those ridges, burrows, linear markings, very commonly found on, for example, in between the webs of the hands. So in between the webs of the hands, the wrists, the elbows. These are going to be very, very itchy. The patient's also going to be presenting with excoriations. It can also present in the axilla, the breast area, also the umbilicus, even the penis, the scrotum, like I said, the finger webs. And the thing about scabies is that the itching is going to be worse at night. So it's going to be more severe at night, which makes sense because this is where they come out at night and they like to feed. That's why they're more itchy at night. Now, diagnosis, we're going to do a microscopy, right? That's when we look at the mites under mineral oil. So we're just going to scrape it and look at it. We can also do a dermoscopy, and that's when we can look at the mites also. And once again, treatment's going to be permethrin 5%. So permethrin 5%, right? Lice was permethrin 1%. Scabies is permethrin 5%. And they really like to test you in regards to educating, once again, the patient. How are they going to apply it? So they're going to apply the permethrin from the neck down. So it's going to be the neck down. So once again, permethrin from the neck down. And the patient has to keep it on for 8 to 14 hours. Okay? 8 to 14 hours from the neck down. And usually you repeat the treatment in 1 week to just make sure that you've gotten rid of everything. Now, for elderly and children, we tend to include also the head because usually the head can also be found in your immunocompromised patients or your elderly patients or your children. So once again, scabies, Sarcoptes scabii, right? It's going to be those burrows, very, very itchy between the finger webs. And also with these patients, you're going to see those burrows, like we said. Treatment's going to be permethrin 5%. You're going to apply it from the neck down. The patient's going to leave it for 8 to 14 hours. You're going to repeat the treatment in 1 week. The next one's going to be crusted scabies. These are hyperkeratotic scabies, also called Norwegian scabies, right? This is usually due to untreated scabies, right? So scabies gone wrong, untreated scabies. The etiology for these are going to be patients that are immunosuppressed or patients that come in contact with typical scabies, but by far the most common ones you're going to see is patients that are just immunosuppressed or your elderly patients. And what you're going to see on physical exam is going to be a thick, scaly, white, gray plaque with minimal pruritus. It can also be very odorous. You'll see fissures, and the areas that are very commonly involved are going to be the scalp, the face, the back, the butt, and the feet. But they can also be generalized. And the thing about these is that they're very difficult to treat. So usually we'll do a combination therapy of oral ivermectin and topical permethrin. And with these patients, it's really important that we isolate them because we want to make sure that they don't infect other people. So the next one we're going to go over is going to be bites. So it's going to be your insect bites. So we'll start with our spider bites. So spider bites, brown recluse spider. So the 2 spider bites that you really need to know about for the PANCE and then just for your clinical year PA school and didactic year exams, your end of rotation exams, it's going to be the brown recluse spider and your black widow. Those are the 2 ones that they really like to test. So I'm from Texas, and in Texas we have a lot of those brown recluse spiders. Specifically, I'm from San Antonio, so I saw a lot of patients that would come in with brown recluse spider bites. So brown recluse spider bites, usually found in the Midwest or the Southeast, right? And usually it's going to be a patient that is disturbing the area where the spider lives, which is the common cause of where we would see the patients that were coming in with these brown recluse spider bites. A lot of these these patients that came in and saw us were like construction workers. That was the majority of the ones that we saw. Patients that were just working down in their attic and they got bit by a brown recluse spider. So the thing that you need to know about this one is how does a spider look and how does a bite look and how to treat this patient. So how does a spider look? So the spider is going to have that violin shaped dark brown marking on its cephalothorax. So once again, that's usually the keyword for this one. It's going to be that violin shaped dark brown marking on its cephalothorax. So cephalothorax, violin shaped dark brown marking. And this patient is going to be presenting with a macular papular exanthem, fever, headache, malaise, arthralgias, nausea and vomiting, and usually you're going to see your red and white and blue sign. Red, white, and blue sign, which is going to be your peripheral edema, blanching, central volaceous area. That's why it's called your red, white, and blue sign. Peripheral edema, blanching, central volaceous area. If it helps you out, this is kind of how I remembered this one for the PANCE and for the end of rotation exam, is that Texas flag, red, white, and blue. Even though the US flag is also red, white, and blue, but Texas flag, we think about red, white, and blue. That's how it helped me memorize that. It's usually found in the southern states. I think about Texas, red, white, and blue, brown recluse spider. So if it helps you, definitely use it. With these patients, the wound can actually progress to becoming necrotic, and it can also form a deep ulcer. Why? Because there's a lot of venom proteins in the venom that can cause this ulceration. So treatments for this are going to be rice, rest, ice, elevation, compression, and then of course tetanus, what we're going to give these patients if they haven't had a tetanus within 10 years, since like I said, a lot of these patients encounter these spiders whenever they are in an area where they shouldn't be, construction workers, for example, being in the attic. And usually treatment is going to be supportive, so cleaning the wound, cold compresses, pain control for these patients. Now, these patients can actually develop hemolysis, renal failure, anemia, and hypotension, but it's very, very rare. Just make sure we're looking for these red signs. So once again, the keyword for this one, right? Looking at the spider, how does it look? Violin shaped dark brown marking on its cephalothorax. And where do these spiders live, or are they located in the Midwest or in the Southeast area? Texas, think about Texas. And usually with these patients, how are they going to present, right? You're going to see that red, white, and blue sign, peripheral edema, blanching, central volaceous area. And just treatment's going to be just rice, rest, ice, compression, elevation, and making sure that we control their pain, and then tetanus if the patient has not had their tetanus shot within 10 years. The next one's going to be a black widow. So with their black widow, right, that's going to be the dark black with your hourglass, your red hourglass on the spider. So black spider, hourglass on the spider, it's going to be red. And with these patients, they're going to be presenting with more neurological symptoms. Why? Because this black widow really likes to release that neurotoxin. And this patient is going to be presenting with severe pain. They're going to have minimal local reactions. They can also present with muscle cramping, nausea and vomiting, abdominal pain, dizziness, chest pain, respiratory difficulties. And the thing about this one is that it's not deadly and it doesn't really cause severe effects in your healthy adults, but in your children and elderly, they can cause very severe symptoms and it can even be deadly. And these patients can also present with elevated blood pressure and heart rate. So once again, this is usually, in general, for these patients, supportive treatment. You really don't need to do a lot for these patients. So the next one we're going to go over is going to be your tick-borne illnesses. So the next one is going to be your Rocky Mountain spotted fever. This is the most common fatal tick-borne infection. And usually these patients are going to be presenting with a triad of a fever, a rash, and then some type of history of a tick bite. So etiology, usually these patients tend to present during the springtime, very commonly found with these ticks in the southeastern US with these patients. And they're going to be presenting with a severe headache. Then it's going to be an abrupt onset of a severe headache, nausea and vomiting, malaise, myalgia, so body aches, fever, chills, shaking, rigors, right? They're rigoring, shaking, pink blanchable macules to deep red papules that are commonly found where? On the wrists, the forearms, and the ankles. And that's a key about this one, and how you can kind of differentiate this one from Lyme disease is where it's located. So this one's going to be once again commonly found on your wrists, your forearms, and your ankles. And the disease progresses to petechial and involves the trunk, extremities, and this one is also going to involve those palms and the soles of the feet. So the thing about rashes just in general is that there's not a lot of rashes that involve the palms and the soles. And this rash found in Rocky Mountain spotted fever does involve the palms and the sole. So just make sure you know that's in comparison to Lyme disease. This one once again is going to involve the palms, the soles of the feet. And just how is it going to present? So early, it's going to be blanchable. Late, it's going to be hemorrhagic. And the thing about this one that is can also become necrotic. And we're really trying to prevent fulminant Rocky Mountain spotted fever because this is very fatal. This is where the patients start presenting with neurological symptoms, right? And usually the rash is going to be gone by then. So diagnosis is going to be a clinical diagnosis, and we can confirm it later, and treatment's going to be with doxycycline. So doxycycline is going to be the treatment regardless of the age of the patient. Because when we think about Lyme disease, doxycycline is also what we use. But of course, if the patient's pregnant or if they're a child under the age of 8, we do amoxicillin, right, for Lyme disease. Well, in Rocky Mountain spotted fever, since it's very serious and we're trying to prevent it into becoming fatal and from the patient developing neuro symptoms, is that with these patients, we're going to treat them with doxycycline regardless of the age. So regardless of how old they are, doxycycline. So make sure that you know that. Something very commonly tested. So once again, Rocky Mountain spotted fever, right? Most common fatal tick-borne infection. And with these patients, they're going to be presenting with that rash. It's going to be a pink blanchable macules to deep red papules that commonly are found in the wristiforms and the ankles. And it's going to progress to involve the trunk and extremity. And this one's going to involve what? The palms and the soles, right? And it's going to be a patient having a history of the tick. And also something that's very commonly tested is going to be what is the bacteria that causes this. It's going to be Rickettsia rickettsii. So Rickettsia rickettsii, Rocky Mountain spotted fever. How I memorize is going to be RR, right? Rocky Mountain spotted fever, Rickettsia rickettsii. And with these patients, treatment is going to be doxycycline regardless of the patient's age. Okay, so the next tick-borne disease is going to be Lyme disease. So once again, this is going to be ticks. The infection that is associated with Lyme disease is going to be Borrelia and Borrelia burgdorferi, and this is going to be a spirochete. So once again, Borrelia burgdorferi leads to for Rocky Mountain spotted fever. It's what? It's Rickettsia rickettsii and Borrelia burgdorferi for Lyme disease. So this is a spirochete. Usually this is commonly found in Mideastern and Midwestern US, and very commonly found usually in late May through early autumn. Usually in the question stem, it's going to be any patient that was out in camping or they were running through a wooded area. Wooded area is another key word for this one. And the bites are asymptomatic. Sometimes patients don't even know that they have them. Sometimes there's patients that will come in and they still have the tick intact on their skin. And with these patients, usually what we think about is erythema migrans, and that's going to be the keyword for this one, right? Don't confuse it with erythema multiforme, right, or erythema infectiosum. No, it's going to be erythema migrans, and that's how they really like to also confuse you in regards to the exam, is that I've seen them where you are reading the question stem and you're like, Lyme disease, and then they would say, what would you expect to see in your physical exam, or what's the name of the rash, which is going to be central clearing with a necrotic center. So what's the name of this rash? And then they'll put a bunch of erythema on there. It's going to be erythema migrans, right? Erythema migrans. So stage 1, this patient's usually going to have early localized disease up to 30 days post-tick bite. There's going to be an erythematous plaque. Erythema migrans is what you're going to see. Once again, erythema migrans, right? Central clearing with a necrotic center. The patient's going to be presenting with fever, chills, myalgias, headache, weakness, photophobia, lymphocytoma. And then there's stage 2. So this is the second stage after this. This is where it's been disseminated, but it's early dissemination. It's days to weeks after the patient has been bitten by the tick. And this is where the patient is going to be presenting with those neurological symptoms, right, and musculoskeletal symptoms. So usually with these patients, they're going to have carditis, so have peripheral neuritis, radiculitis, cranial neuritis, meningitis, secondary lesion, right? They can also present with AV nodal block arthralgias also. And then we have stage 3. This is where it's late disseminated. So these patients have persistent infection, and this one develops months to years later. And these patients are going to be presenting with a lot of musculoskeletal symptoms. So they'll have arthritis. They can also present with chronic encephalopathy or polyneuropathy. And once again, make sure that you know what stage the patient's presenting in. So stage 1, it's going to be localized up to 30 days post-tick bites. This is usually those fever symptoms. And then stage 2 is when it's early disseminated, so days to weeks after the patient has been bitten, so those neurological symptoms and musculoskeletal symptoms. Stage 3 is going to be late disseminated. This is where the patient has that persistent infection. It develops months to years later. They can get that chronic encephalopathy, right? That persistent arthritis. And diagnosis is usually going to be a clinical diagnosis, especially for your early Lyme disease. If it's late stage Lyme disease, we're going to do a serological testing for these patients. And treatment for these patients is usually going to be, if it's early or late Lyme disease, it's going to be with doxycycline. And like we said, remember with Lyme disease, doxycycline, if the patient is not a child under the age of 8, or if they're pregnant. If they're pregnant or if they're children under the age of 8, then these patients get amoxicillin. Or if they're allergic to doxycycline, then they can get amoxicillin. They can also get cefuroxime or cefotaxime. So once again, doxycycline is going to be the treatment. But if the patient is a child less than the age of 8, or if they're pregnant, then they get amoxicillin. Versus Rocky Mountain spotted fever, it's doxycycline no matter what. And this is what they really like to quiz you on and confuse you on, so make sure that you know that. So once again, Lyme disease, Borrelia burgdorferi, right, spirochete. Your Rocky Mountain spotted fever is going to be your Rickettsia rickettsii, right? Treatment for Rocky Mountain spotted fever is going to be doxycycline regardless of the age. Treatment for Lyme disease is going to be doxycycline. If the patient's pregnant or if they're children under the age of 8, it's going to be with amoxicillin. With Lyme disease, we think about what? Erythema migrans. That's going to be that central clearing with a necrotic center. So the next one that we are going to talk about is going to be eruptions and desquamations. So why don't we talk about our acnes first. So let's go into acne vulgaris. So acne vulgaris is going to be a disorder of the sebaceous follicles. Basically, there's an increase in sebum production. So there's keratin and sebum, so this causes hyperkeratosis, and it's usually due to P. acnes. So P. acnes is going to be the common bacteria that's usually associated with acne vulgaris. So it's going to be your Propionibacterium acnes, which is a gram-positive bacteria, right? So just make sure you know that. You can also get a question on that also, and I've seen it. So very commonly found in your adolescence, right? Especially since they have all these hormonal changes. Also, if an adolescent has a positive family history of someone in the family suffering from acne, the patient's very prone to getting acne also. So it tends to peak at the ages between 15 to 18. It'll usually go away by the age of 25, but it can also occur later in age, like in the patient's 40s. And some of the things that can actually make this worse is certain drugs like lithium, steroids, oral contraceptives, androgens, bromides. Also, if the patient's stressed, it can actually make the acne vulgaris worse. And also, this one's acne vulgaris is worse during the fall and winter if it's a woman, especially during their menses. And like we discussed, it's related to the patient's hormones. So how is this patient going to present? What are you going to see on physical exam, the signs, symptoms? So you're going to see this variety of comedones. So you'll see open comedones, which are going to be your blackheads. The closed comedones are going to be your whiteheads. You'll see papulopustules, nodules, cysts. There's going to be depression. You can also see hypertrophic scars. And usually it's going to be on the face, neck, upper trunk, upper arms, very commonly associated in these areas. And then, of course, the face is like very traumatic, especially for teenagers. And the thing about acne vulgaris is diagnosing it in regards to, is it mild acne vulgaris, is it moderate acne vulgaris, or is it severe? And it's really that important that you know which type it is, because that's how you're going to treat it. So if it's mild acne vulgaris, it's going to be comedones with few inflammatory lesions. If it's moderate acne vulgaris, it's going to be comedones with marked number of inflammatory lesions. If it's severe, this is where you see extensive inflammatory lesions, and then you also see scarring. So once again, mild comedones with few inflammatory lesions. Moderate, it's going to be comedones with marked number of inflammatory lesions. And severe is where you already have extensive inflammatory lesions, and then on top of that, you also have scarring. So treatment for this is just removing the plugging, right? Decreasing the sebum production and ensuring that we get that colonization of bacteria under control. So we're going to be treating that and to prevent the scarring. So that's really important. And then of course, another one is that if we are going to prescribe Accutane, it's really important that the patient gets a pregnancy test before they start the Accutane. They also need to be on oral contraceptives because this can cause, if the patient does become pregnant, it can really damage the baby. And one of my friends, my classmates, she actually works at the dermatology PA, and she says that for their patients, they have to sign a form, a waiver saying that if they do get pregnant, just informing them of the complications if the patient does get pregnant. And usually she said that they have to be on 2 types of oral contraceptives before they start Accutane. So with these patients, right, just ensuring that we also educate the patients. So ensuring that they adhere to the medications. So the medications we're going to prescribe them, they won't see results until a few weeks later. So ensuring that they adhere to the medications because it's going to take a while. It's not going to be immediate before they start seeing results. Also ensuring that they moisturize their skin, avoid any type of drying over-the-counter products, oil-free cosmetics for women, right? Their diet also can really help in regards with their acne, sunblock, and some of the complications of this is by far scarring, and that's one of the ones we're trying to avoid. So treatment, like I said, is usually going to be depending on the type of acne they have. So if it's mild acne vulgaris, usually we'll start with topical things like benzoyl peroxide or topical retinoid for these patients. If it's moderate, then we're going to do the topical combination therapy that we discussed with mild. And on top of that, you're going to add either an antibiotic or retinoid, or you can add antibiotic retinoid, plus you're going to add a benzoyl peroxide or a retinoid with these patients, plus an antibiotic. Or you can do an oral antibiotic plus a topical retinoid plus benzoyl peroxide, or you can do an oral antibiotic plus a topical retinoid plus benzoyl peroxide plus a topical antibiotic. So I know this is like a mouthful, but this is what you can do for these patients for moderate. So once again, topical combination therapy for these patients, and then on top of that, you're going to do topical combination therapy, benzoyl peroxide plus an antibiotic or retinoid plus either benzoyl peroxide or retinoid plus benzoyl peroxide plus antibiotics for these patients. Or you can just do an oral antibiotic plus a topical retinoid plus benzoyl peroxide. And as you can see with mild, usually it's going to be topical, right? Either a topical retinoid or some type of benzoyl peroxide. And severe, this is where you get an oral antibiotic. You get that topical combination therapy, benzoyl peroxide plus an antibiotic or retinoid plus benzoyl peroxide or a retinoid plus an antibiotic. Or you can just do oral isotretinoin. And like we discussed, these patients do need to be on treatment on oral contraceptives and ensuring that these patients are not pregnant. So the next one's going to be acne rosacea. Usually we think about this, the acne of older patients, right? And when I say older patients, not adolescents. So usually this one's going to be the flushing and blushing, right? And it's due to sebaceous hyperplasia. They're going to have edema and fibrosis. And the thing about this one is that it's not hormone related in comparison to acne vulgaris, which is hormone related. So etiology is usually going to be between the ages of 30 to 50-year-olds, and there's going to be certain things that will make a patient to flare up. So it's very commonly associated with alcohol, sunlight, hot beverages, spicy food, and stress. This is very commonly tested, so make sure that you know this. Once again, acne rosacea, alcohol, sunlight, hot beverages, spicy food, and emotion, no stress can actually cause a patient to flare up. So what are you going to see on physical exam? This patient is not going to have any comedones, so there's going to be absence of comedones. It's going to be episodic, and the patient's going to be presenting with flushing, erythema, telangiectasias, papules, pustules, Phimosis changes, usually on the nose, and usually on the question stem, you'll see it on the nose or on the cheeks. It can also present on the forehead or the chin, but like I said, usually on the cheeks or the nose is what you're going to see. And usually when we think about the nose, it's going to be the rhinophyma, right, that really enlarged nose. It can also involve the eyes with these patients. And treatment's just going to be ensuring we educate the patient on preventing these flare-ups. Use sunscreen, avoid any type of the triggers like we discussed. Avoid your spicy foods, avoid any type of hot beverages, coffee, hot teas. And treatment that we can do is we can do something like surgery or laser surgery. It's usually last line, right? For the papules and pustules, we're usually going to do metronidazole. Next one's going to be erythema multiforme. This is going to be cutaneous reaction pattern of blood vessels in the dermis within second epidermal changes. This is usually benign, and the thing about this one is that it frequently reoccurs. And etiology, 50% are under the age of 20, usually males. And the thing about erythema multiforme is that it's associated with herpes simplex virus 1 and mycoplasma. This is something that they really like to test, so just make sure that you know this. So once again, erythema multiforme, it's commonly associated with herpes simplex virus 1 and mycoplasma. It's also associated with medications, so it's going to be a patient with a history of sulfonamides, phenytoin, taking barbiturates, penicillin, allopurinol, right? Those culprits that are commonly associated with Stevens-Johnson syndrome and toxic epidermal necrolysis. So what are you going to see on physical exam? So what you're going to see is going to be usually bilateral. It's going to be symmetric. You're going to see an erythematous iris-shaped papular and vesicular bullous lesions. It's going to be very, very itchy, painful, dual red macular papule and vesicles and bulla in the center of the papule. Usually you're going to see those typical target lesions. You're going to see redness with ring of white and then another ring of red, so those target signs. And that's usually what is the key for this one, for erythema multiforme. It's going to be those target signs. They literally look like Target. You think about the Target store, that Target that they have looks like that on the physical exam. Very commonly found in the extremities, the palms, the soles, the mucous membranes like the lips, the nasal, the conjunctiva, the vulva, and the anus. It can also present on the face, the penis, and the eyes. Diagnosis is going to be clinical. It has a connection, like we said, with herpes simplex virus and your mycoplasma. And then once again, just make sure that we don't associate this with Stevens-Johnson syndrome. So with erythema multiforme, there's two types. You have your erythema multiforme minor, and then you have your erythema multiforme major. So you have to make sure that you are familiar with each one. Which one has a positive Nikolsky sign that you touch on, all right, and it literally falls off, and which one involves mucous membranes. So erythema multiforme minor, this one is going to have no mucous membrane involvement. No mucous membrane involvement, right? Once again, erythema multiforme minor, no mucous membrane involvement. And with these patients, you're going to see vesicles, no bulla. You're going to see those classic target lesions like we discussed. And then we have erythema multiforme major. This one always involves the mucous membranes. This one is Nikolsky positive. You're going to see confluent bullous, and this patient is going to be presenting with systemic symptoms. And since it does involve the mucous membrane, this patient is going to be presenting with stomatitis, colitis, so it's going to be very painful whenever they eat. It can also even involve the vaginal area because we have a lot of mucosal area there. So the patient is going to be presenting with vulvitis, balanitis, so they're going to have a lot of pain whenever they go to the restroom. And it can also involve the eyes, right? It involves those mucous membranes, so the patient's going to be presenting with conjunctivitis, keratitis, ulceration. So treatment, usually, since it is associated with herpes simplex virus, we tend to do something like oral valsiclovir or famciclovir. If the patient is severely ill, usually we think about erythema multiforme major. We're going to give these patients glucocorticoids, so something like oral prednisone. So once again, erythema multiforme, right, that is usually associated with herpes simplex virus 1 and mycoplasma. It's also associated with your medications that are the culprits for, we think about Stevens-Johnson syndrome and toxic epidermal necrolysis. So your sulfonamides, right? We think about your phenytoin, some of your anti-epileptics, barbiturates, also penicillin and allopurinol. And then you are going to see on physical exam those target lesions. That's going to be the keyword for this one. You have two types, erythema multiforme minor and erythema multiforme major, right? Erythema multiforme major positive mucosity sign, systemic symptoms, involves the mucosal membranes, the eyes, the mouth, the vagina, and this patient, we said positive mucosity sign, erythema multiforme minor, that's going to be those classic target signs, does not involve the mucosal area. And treatment's going to be usually with oral valcyclovir or famciclovir, especially if we suspect that it's associated with herpes simplex virus. If it's severe, like erythema multiforme major, this is we're going to do glucocorticoids. So our next one is going to be our xanthomatous drug reaction. This is going to be a delayed reaction, and it's the most common type of cutaneous drug reaction. Commonly associated with penicillin, your antiepileptics, once again, carbamazepine, allopurinol, sulfonamides, NSAIDs, isoniazid, barbiturates, benzodiazepines, and tetracyclines. Usually it's limited to the skin, but it can also involve the buccal mucosa. It usually starts in the trunk, and then it starts moving centrifugally to the extremities. It's going to be symmetric, and it looks like measles because it has that more billiform appearance. So just make sure when you're reading that question stem that if it looks like measles, don't choose measles, especially if it's an older patient, it's not a child, and the patient has a history of taking any of the medications that we discussed. Think about your xanthomatous drug reaction. This patient is going to be presenting with an erythematous macule and infiltrated papules. It's going to be very itchy, and it's going to be diffuse, right? They can also present with a fever. Treatment for this is just discontinuing whatever the medication the patient's on, and that's actually going to be the first line treatment. Discontinue whatever the patient was on. You're also going to do potent topical corticosteroids. You can do oral antihistamines since the patient's going to be very, very itchy. The next one's going to be a fixed drug eruption. This is going to be a delayed reaction, and it's a formation of a solitary erythematous patch or plaque that reoccurs at the same area once again, same site with re-exposure. And that's the key about this one, and that's why it's called fixed drug eruption, because it's going to reoccur every time the patient is exposed to whatever caused it, to whatever they're allergic to in that same area. So if it occurred, for example, on the forearm, it's going to occur in that area again once a patient gets exposed to that, again, whatever was the culprit. So some of the things that can cause fixed drug eruptions: laxatives, tetracyclines, metronidazole. Once again, the common culprits for like every drug reaction: sulfonamides, antiepileptics like barbiturates, NSAIDs, salicylates, even food coloring, oral contraceptives, quinine. And once again, these recur at the same site, and that's a key word for this one and how you can differentiate it in comparison to all the other ones. So it can occur anywhere in the body, but usually it's going to be in an area of some type of antecedent trauma. And like we said, it's going to be fixed. It can occur in the mouth, it can occur in the genital area, the face, and the acral areas, and it's going to be localized, right? Localized. It's going to be staying in that area. So early lesions, you're going to see a sharply demarcated erythematous macule. It's going to be very itchy, painful, and burning. It's usually solitary, but it can also become large. Lesions will become edematous. They're going to form a plaque, which can evolve to a bulla, and then it can cause erosion. So treatment for these patients, usually it resolves days to weeks after you discontinue the medication. So once again, the key for these is also the first line, always discontinue the medication. Key, first line, if the question asks you what's the next step you're going to do, discontinue the offending medication. Also with these patients, they're going to be presenting with pain, especially since it can involve the mucosal area for these patients. If it's a non-eroded lesion, we can do something like a potent topical corticosteroid. If it's an eroded lesion, then with these patients, we're going to do antimicrobial ointment, right, and dressing. The next one's going to be your DRESS syndrome, or your drug-induced hypersensitivity reaction, or DRESS, which is going to be your drug-related eosinophilia with systemic symptoms. So this is going to be an eruption, and just like it is DRESS, right, with systemic symptoms and internal organ involvement. So it can involve the kidney, the liver, the heart, the bone, marrow. These are usually the targets that it involves. And what are the culprits? Medications, once again, keep repeating this over and over again: penicillin, metronidazole, anti-TB medications like isoniazid. This is one of the key ones that's associated with this one. So make sure that when we're probably going to go over in pulmonology for tuberculosis, but just make sure that you're familiar with the medications that are associated with certain side effects, and this is isoniazid, one of the ones. NSAIDs, certain illnesses like diclofenac, meloxicam, right? Anti-HIV medications, calcium channel blockers, phenobarbital, allopurinol. And what you're going to see on your physical exam is going to be an exanthem. It's going to be an erythematous central facial swelling, fever, malaise, lymphadenopathy, involvement of other organs like the livers and kidneys, like we said. And these patients are going to have eosinophilia, abnormal LFTs, because like we said, it involves what organs? The liver, the kidney, heart, and bone marrow. So that's why this patient is going to be presenting with abnormal LFTs, an enlarged spleen and liver, also on your physical exam. And usually they're going to have a nonspecific rash that starts in the third week of the patient starting a new medication. They can have mucosal involvement, and if they do, the patient's going to be presenting with erosions, like a really inflamed red pharynx, colitis, enlarged tonsils. And this is usually going to be a clinical diagnosis. Just make sure that we are asking the patients about the drugs that they are taking. Did they start any new drugs? Did they just get prescribed new drugs? Make sure that we do a good physical exam, do labs, do CBC, LFTs, BU, and creatinine, right? We're looking at their liver and their kidney. And usually they have to have 3 of these diagnostic criteria. So they have to have a drug eruption, hematological abnormalities, and systemic involvement to have the DRESS syndrome. First line we're going to do, once again, like we discussed with everything else, with the SJS, toxic epidermal necrolysis, everything that we discussed is stopping the medication that we suspect is causing this. So stopping it or substituting for another medication. If it's an antibiotic, switch to another one. If it's an anti-epileptic, switch to another one. And with these patients, if they don't have a severe case, we can do something like topical steroids or antihistamines. If it's severe, they get systemic corticosteroids for these patients. Next one's going to be the big bad boys, Stevens-Johnson syndrome and toxic epidermal necrolysis. I saw a lot of these during my burn rotation, and a lot of patients that you have come into the ER, for example, you suspect that they may have SJS or toxic epidermal necrolysis. These patients could refer to a burn center. And so we saw a lot of these patients. It's a very, very sad disease, and patients can quickly die from this if they're not treated. I saw 2 patients die during my rotation from SJS/10 or just full-blown toxic epidermal necrolysis. So let's go into each one. So Stevens-Johnson syndrome, toxic epidermal necrolysis. So they're going to be delayed reactions, and like I said, these are going to be life-threatening mucocutaneous skin reactions. So these are severe, critical skin reactions. The causes is usually idiopathic. We know it's caused by certain medications. And what happens in regards to the pathophysiology is that there's apoptosis, so there's cell death of keratinocytes, and there's some type of cytotoxic immune reaction against your own skin, right? The common medications that are very commonly associated with this is going to be your sulfa antibiotics, sulfasalazine, allopurinol, tetracycline, anticonvulsants, NSAIDs, nifurapine, and thiacidazone. So whenever we think about this mnemonic, I heard this mnemonic in PA school, use it or lose it, but it's Satan, S-A-T-A-N. So S is going to be for your sulfa antibiotics, right? Sulfasalazine. A is going to be for allopurinol. T is going to be for tetracycline. The second A is going to be for anticonvulsants. And then the N is going to be for NSAIDs and nifurapine. So that's going to be the mnemonic. If it's helpful for you, definitely use it. It was for me. And I got asked to pimped on this a lot during my rotation, and that mnemonic really helped me out. So physical exam, you're going to see extensive necrosis and detachment of the epidermis and mucosal surfaces. Once again, extensive necrosis and detachment of the epidermis and mucosal surfaces. Usually the patient's going to present with 1 to 3 weeks after starting a new medication. They're going to be presenting with fever, headaches. They're going to have a lot of systemic symptoms, rhinitis, arthralgias, myalgias. They're going to have initial symmetric eruptions on the face, upper trunk, proximal extremities. It's going to be very painful, and it's going to be more painful than itchy for these patients in comparison to all the other rashes that we discussed. And the thing about this one is the rash can rapidly extend to the rest of the body. Remember, we had a patient that was transferred to us. He came in on a Monday. They had diagnosed him with Stevens-Johnson syndrome/10. And the thing about diagnosis in the burn center is that all these patients get a biopsy to confirm that the patient has SJS, TENS, pemphigus vulgaris, any of your severe skin disorders. So all these patients get a biopsy. And so we had this patient come in on a Monday, and he when he came in, he was walking perfectly fine, and I remember seeing him, and of course I'm a student, so I told my preceptor, "Hey, I don't know, I don't think this guy has like SJS or toxic epidermolysis. I don't know why he's here." And he told me, we're just gonna observe him a few days because you never know, it will pop out of nowhere. And yeah, the next day when I went to go see him, it was everywhere. It was in his throat. Like he had a catheter in because it was really painful for him to urinate. We had a place of a tube to feed him, so we had to place a feeding tube for him because it was really painful for him to swallow. He had it all over his lips and his mouth, so it was within a day he went from 0 to 100. And so that's the thing about this one. Like I said, it can extend to the rest of the body really, really quickly. So you're going to see erythematous, irregularly shaped, dusky red to purpuric macules that progressively coalesce. And they can present with skin tenderness. They're going to have that conjunctival burning and itching. The skin is going to be very painful. It's going to be burning, tenderness, paresthesias also. And I had a lady also, she had a lot of risk factors. She was diabetic, and she had actually been exposed to allopurinol. And so when she came in, she was in really bad shape. What had involved her mouth was just completely like enlarged. Her lips were just enlarged. Her mucosa was falling out. Her eyes were just extremely enlarged. She had a problem seeing because they were just really bad. And she had, once again, she had it in the vaginal area. She had a feeding tube. Unfortunately, she ended up going into septic shock and she ended up dying. But I remember her case was really, really sad. And like I said, it involves everywhere. It can involve the eyes. A lot of these patients get ophtho to come and evaluate them, also look into their eyes because it can involve everything: the eyes, um, everything, the vagina, the pharynx. It's really, really painful for them to eat and swallow. So, like we said, photophobia, painful micturition, dysuria. These patients are going to be presenting with anxiety or even PTSD. And with these patients, lesions are going to evolve to flaccid blisters, and they're going to spread with pressure, and they're going to be breaking easily. So they're going to have that positive Nikolsky side. Literally on this patient, we would go like this in our skin, and our skin would fall off, which makes sense, right? Because when we think about the pathophysiology, there's apoptosis of the keratinocytes. So that makes sense in regards to these patients. And they're also going to have necrotic epidermis that's easily detached at pressure points or by friction trauma, like I discussed. Large areas of exposed red oozing dermis. They can have mucosal involvement. It can precede skin eruption. They're going to have erythema to painful erosions, usually in the buccal area, the ocular general area. And like we said, this is a dermatological emergency. These patients get referred to a burn center. And the mortality rate is usually 5 to 12% for Stevens-Johnson syndrome and greater than 20% for toxic epidermal necrolysis. And the thing about Stevens-Johnson syndrome and toxic epidermal necrolysis, and what they really like to test you, is how much body surface area is involved. So if less than 10% body surface area is involved, then it's classified as Stevens-Johnson syndrome. If it is between 10 to 20%, then it's Stevens-Johnson syndrome / toxic epidermal necrolysis. If it's greater than 38%, it's toxic epidermal necrolysis. So once again, this is how you're going to diagnose these patients, and that's how we diagnose our patients. They would have SJS/10s or full-blown 10s. So SJS less than 10%, 10 to 20 is going to be SJS/10, and then 30% greater than 30 is going to be 10. The key for this one is just making sure that we recognize it early. You have a patient coming into your ER or into your family clinic, and they're presenting with symptoms, or you suspect that they might have 10 or SJS, you need to refer them to a burn center as soon as you can. So early recognition, discontinuing the drug that is causing them. This supportive care really is how we care for these patients. So we give them fluids. And like I said, these patients get referred to a burn center or ICU, especially if they have more than 25% of their body surface area involved. And like we discussed, anything that involves the eye, ocular involvement, we consult with ophtho. Some of the treatment that we can do is high-dose IVIG, right? IV immunoglobulin, IV fluids, glucocorticoids. erythromycin for the eye lesions that they have, and complications for these patients. These patients can go into sepsis, right? So once again, this is very commonly tested. Make sure that you know with Stevens-Johnson syndrome, toxic epidermal necrolysis, the body surface area less than 10% is Stevens-Johnson syndrome. Stevens-Johnson syndrome /10 is going to be between 10 to 20%. Toxic epidermal necrolysis is going to be greater than 30%. This patient's going to have a positive Nikolsky sign, right? In these patients, you need to refer them to the burn center whenever you suspect them, especially if the patient's already presenting with symptoms and they have more than 25% body surface area, then these patients get transferred to the burn center. We would get patients that would get transferred to the burn center with like dress syndrome, just because they wanted to make sure that the patient wasn't going into Stevens-Johnson syndrome or toxic epidermal necrolysis. So if you suspect it, make sure that you transfer these patients. And like we discussed with these patients, right, we said that positive Nikolsky sign is going to be the key. And medications that are very commonly associated, it's going to be your Satan, right? Sulfa antibiotics, sulfasalazine, allopurinol, tetracyclines, anticonvulsants, or any of your anti-epileptics. And then the last N was going to be some of your NSAIDs, right? And nevirapine also. So let's get into the next one. It's going to be keratotic disorders and neoplasms. By far, this is commonly found in patients that are older. So let's go into each one. So let's go with seborrheic keratosis. Seborrheic keratosis is going to be the first one. Etiology, commonly found in patients that are older than the age of 30, more commonly found in males than females. And this can occur in any part of the body, but it does not occur on the palms of their soles. So remember when we were discussing, there's very few rashes that occur on the palms and the soles. So when we think about the palms and the soles, right, we were discussing which tick-borne illness, Rocky Mountain spotted fever. When we're thinking about our children, right, that are presenting, especially if the child is of Asian ethnicity and they have a rash that's presenting in their palms and soles and it's involving the eye, we think about what? Kawasaki's disease, because there's very few rashes that involve the palms and the soles. So with seborrheic keratosis, right, this one can arise everywhere except for the palms and the soles. Very commonly found in males, we said, especially males that are older than the age of 30. You're going to see a sharply marginated pigmented lesion. Usually it's going to be a black, tan, flesh-colored, pink, blue, gray. They're going to be multiple and they can be extensive. Usually they're papular. They can appear macular. It's going to be superficial epidermal growth. They can become into a plaque. And usually you're going to see that velvety texture or verrucous, wart-like, waxy, greasy. And that's a keyword for this one, right, is on your physical exam, you're going to see a velvety texture or verrucous, wart-like, waxy, greasy, stuck-on appearance. Once again, that's going to be the keyword for this one. Is going to be that stuck-on appearance, velvety texture, or verrucous, wart-like, waxy, greasy. So you're going to see an area that's irritated. The patient just is complaining that it's just cosmetically ugly, right? On the back, you can present like a Christmas tree distribution. And you want to make sure that when you are doing a physical exam on these patients, you're comparing them to the other ones, just looking for the ugly duckling, right? Trying to rule out things like your bad cancers, like our melanomas, right? So diagnosis for this, we are just going to make sure we do a thorough physical exam, look at their skins. We can pick at it and scratch at it. Usually it's going to crumble, flake, or lift off. And you're going to see that superficial waxy character. We can also biopsy it. We can do a dermoscopy if needed. And treatment for this is really just treatment for patients that just thinks it's cosmetically ugly, right? So it's more cosmetic than anything. So we can do a curettage. We can also do cryotherapy, electrodesiccation. Next one's going to be actinic keratosis. These are pre-malignant lesions. So seborrheic keratosis is usually benign versus your actinic keratosis. These are going to be pre-malignant lesions. These have the potential of transforming into full-blown squamous cell carcinoma. So these are bad, right? Bad, bad, bad. And the cell of origin is going to be your keratinocytes, which makes sense, right? Which is a cell that's associated with squamous cell carcinoma. So keratinocytes, actinic keratosis, once again, very commonly found in your mouths, especially individuals that work outside a lot. So it's going to be your outdoor workers, prolonged UV exposure, and usually the risk increases with age. very commonly found in your fair-skinned patients. Also, if they have a history of immunosuppression, or if they have any type of genetic syndrome like albinism, right? Because they have skin that has decreased pigmentation, so they're very prone to getting actinic keratosis. And with these patients, they're going to be presenting with a tender excoriated, and it's usually going to be on areas that are skin exposed. So the head, the neck, the forearms, the face, and the hands. So any area that is exposed to the sun the most. And you're going to see an erythematous papule / thin plaque with rough, gritty scale. It's going to be adherent, hyperkeratotic, skin colored, yellow, brown, dirty, reddish tinge. And it's going to be coarse like sandpaper. And that's a keyword for this one, right? That rough, gritty scale, coarse like sandpaper. And sometimes the patient can have one or they can have several. And like we discussed, diagnosis is going to be a clinical diagnosis, right? We can do a biopsy, especially if it's like very hyperkeratotic. And the thing about this one is that it does not bleed with excoriation, and that's how you can differentiate this from your squamous cell and your basal cell carcinoma, is that this one does not bleed with excoriation. So treatment, we just want to make sure that we consider the number of lesions, where it's located, right, how thick it is. So if it's a local lesion, usually we can treat it with liquid nitrogen cryotherapy. We can also do curettage or electrocautery. If there's multiple actinic keratosis in one area, then we can do something like topical 5-FU imiquimod cream. And just ensuring that we educate these patients, right? So educating them on ensuring that they follow up with their physical exams, so skin exams every 6 to 12 months, ensuring them that we educate them how squamous cell carcinoma looks like, and ensuring that they wear sunscreen, right? Protect themselves from sun, especially those individuals that are fair skinned and they're out in the sun a lot. The next one's going to be squamous cell carcinoma. So remember that we said actinic keratosis is pre-malignant lesion to squamous cell carcinoma. Now let's discuss full-blown squamous cell carcinoma. So this arises from dysplastic lesions. Once again, the cell that is associated with this is going to be your keratinocyte, which is the same one that is involved with actinic keratosis. Very commonly found in your white males. Males are older than the age of 55 if they're fair-skinned, right? And it's going to be very commonly found in those sun-exposed areas like the head, the neck, the forearms, the hands. Patients usually also have a history of tanning bed use, is also associated with squamous cell carcinoma. UV exposure, chemical carcinogens like arsenic, tar, chronic radiation, HPV infections, especially the genitals and the thumb. And how is this patient going to present? So you're going to see a sharply demarcated macule, papule, plaque, or nodule. They can be either pink, red, or skin colored. They're going to be scaly, hyperkeratotic, exophytic, which means it grows outwards, right? That's why it's exophytic. Indurated, so the lesion's going to feel very thick and firm. And usually what I'll see on the question stems and what you'll see on the pictures is going to be that cutaneous horn. It's going to be crusted, it's going to be friable, and this one bleeds with minimal trauma. And that's how you can differentiate this one from actinic keratosis, which is pre-malignant, right? Pre-malignant actinic keratosis does not bleed with minimal trauma versus squamous cell carcinoma, minimal trauma, it bleeds. It's very itchy, it's tender, and it's firm. So diagnosis is that if you see any keratotic or eroded papular plaque for more than 1 month, usually it's cancer until proven otherwise. If there's no involvement of the dermis, this is going to be squamous cell carcinoma in situ, which makes sense, right? Because it's in situ, in place. Invasive squamous cell carcinoma is going to be squamous cell carcinoma that has already invaded the dermis. It involves the lymph nodes also with these patients. And treatment for these patients, we usually refer them to dermatology, and the standard of care is usually going to be your surgical excision, right? Your wide local excision or your Mohs micrographic, which is usually the keyword for PANCE is going to be your Mohs micrographic surgical excision. You can also give the patient medications like 5-FU, imiquimod, right? And in comparison to basal cell carcinoma, squamous cell carcinoma has a higher risk of mortality. Why? Because it has a higher rate of metastasis with these patients. And all these patients need surveillance for early recognition and treatment of complications once they've been diagnosed with squamous cell carcinoma and they've been treated for it, because they have a very high likelihood that it's going to come back. So it'll reoccur. So we're going to follow up with these patients closely every 3 to 6 months for 2 years. Then after that, every 6 to 12 months for 3 years. Then after that, annually for life. So just thinking about your cancers real quick, right? Actinic keratosis is associated with squamous cell carcinoma. So when we're thinking in a step ladder form, basal cell carcinoma is the least, one would say, it's the most common type of skin cancer, but it has a very low mortality rate. So you have your basal cell carcinoma, the next one's going to be squamous cell carcinoma, and then the third one's going to be melanoma. So melanoma is the baddest of the bad out of all three of them. So it's the baddest of the bad, and it has a very high mortality rate. So we have our basal cell carcinoma, right? Most common type of cancer, but the good thing is that it doesn't have a high mortality rate. And then you have your squamous cell carcinoma, which does have a high mortality rate. And the worst one's going to be your melanoma. So it's going to be that step ladder approach. And if you kind of think about those in your mind, then you should do well on your exam, whether it's for the PANCE or for your end of rotation or for your didactic year. So the next one's going to be your squamous cell carcinoma in situ. We think about Bowen's disease, right? This is usually most commonly due to UV rays, HPV infection, and this one is commonly found usually, and it stays in the epidermis. This patient's going to be presenting with a circumscribed pink-red patch, thin plaque with scaly rough surface, keratotic scale crust, keratinocytes, atypia is confined to the epidermis, and does not involve passidermal epidermal junction. Treatment for this is going to be cryotherapy or topicals. The next one's going to be your squamous cell carcinoma of the nail, very commonly found in your males, age between 50 to 69. This has a very high recurrence rate, especially if the patient does not get treated. On physical exam, you're going to see this warty subungual hyperkeratosis, uncal-lysis oozing, and it's usually, once again, going to be found on the nail, so we're going to see that destruction of the nail plate. And treatment's going to be conservative excision and Mohs micrographic surgery. So next one's going to be basal cell carcinoma, and like we discussed earlier, it's going to be the most common type of skin cancer. It arises from the basal layer of the epidermis. And what types of cells are going to be involved? It's going to be those atypical basal cells. So it's going to be proliferating atypical basal cells. Commonly found in males older than the age of 40. The majority of them are going to be on the face, of like more than 90% are going to be found on the face. Usually the patient's going to have a history of UV radiation. They can also have the PTCH tumor suppressor gene mutation. And once again, this is going to be in your fair skin types, right? Any patient with a history of also immune suppression, commonly found in areas that are some damaged, like we said, the face. And usually this patient is going to be presenting, the first symptom is going to be usually erosion and bleeding with minimal trauma. It's going to be an open sore, reddish patch, shiny bump nodule, and that's a key for this one, right? Shiny bump nodule for basal cell carcinoma, pink growth, scar, and some of the danger sites that we think about if we find them is in these areas, just because these areas are very highly vascularized, it's going to be your medial lateral canthi, your nasal labial folds, behind the ears, the ear canal, and the scalp. And you have different types of basal cell carcinoma. You have your nodule, which is going to be the most common site, most common type. And remember, with basal cell carcinoma, it's going to be that translucent pearly papule or nodule with telangiectasias. It's going to be most commonly found in the head and neck for the nodular type, and you may see an erosion or stipules or melanin pigmentation. It's going to be firm, and it can also be ulcerated. So it's going to be the nodular type. There's also superficial, sclerosing, pigmented, ulcerating type. So there's different types of basal cell carcinoma. By far, the most common type is going to be nodular, like I discussed. So diagnosis, we're going to do a dermoscopy, but biopsy is going to be the best one just to confirm that the patient does have basal cell carcinoma, and we're going to do this before we surgically remove it. So treatment for these patients, we're going to do curette and electrocautery. We can also do cryosurgery, and we're going to excise the cancer with standard 3 to 4 millimeter margins. And like we discussed, the danger sites, right, the face, the ears, the canthi, or if it's sclerosing, then these patients go get Mohs micrographic surgery. If it's non-surgical, we can do something like imiquimod, 5-FU, radiation. And prognosis, we said this one has a very low mortality rate. It doesn't tend to metastasize like squamous cell carcinoma and melanoma. It's very slow growing, and if it's invasive, it's only locally. And metastasis is very rare. So these patients have a very good prognosis. And just ensuring that we follow up with these patients, right, every 6 to 12 months for 2 years, and educate the patient on protecting themselves from skin, right, from the sun, performing skin exams at home, following up with their primary care doctor. So just recap for each one. Squamous cell carcinoma, remember we discussed, we think about those cutaneous horns. Basal cell carcinoma, we think about that translucent pearly papule or nodule with telangiectasias. It's firm. For both of them, they're usually going to bleed with trauma, and that's how we can differentiate these from actinic keratosis, which does not bleed with trauma. Next one's going to be melanoma. We said this is going to be the most malignant skin cancer out of the ones that we discussed. The origin of cell is going to be the melanocyte. That's why it's called melanoma. Most commonly found in women, especially a young woman between the ages of 25 to 29. They're going to have a history of UVA and UVB exposure, tanning beds, and risk factors is going to be the patient's age, fair skin once again, blue eyes, red, blonde hair, freckling. If they have any type of atypical nevis, congenital nevis, if they have immunosuppression, personal or family history of melanoma, UV exposure, and then genetic markers. So this patient's going to be asymptomatic. Sometimes they just develop de novo, right? They sometimes can also rise from a pre-existing nevi, very commonly found on areas that are sun exposed or even in areas that are non-sun exposed. They're going to be pigmented, papules, plaque, and nodules. This is where we think about our ABCDEs, right? Which is going to be asymmetry, B is going to be borders, C is going to be circumference, D is going to be diameter, and E is going to be elevation. So we're going to look at all of these and just look to see if they are abnormal. This is where we look for that ugly duckling. These can bleed, they're going to erode, crusted, and usually the patient's going to be saying that it's been changing in size, and like we said, diameters, ABCs, asymmetry, B is going to be for borders, C is going to be for circumference, D is going to be for diameter, and E is going to be for elevation. So they're going to have a change in any of these. And with these patients, there's different types. Once again, a melanoma. Superficial spreading is going to be the most common type of melanoma. This is where it's going to be found in the back on men, back in the legs in women. It's usually going to be flat plaques with all shades of brown to black, plus red, blue, and white, and large nodes, ulcerations, papules and nodules, horizontal primary growth. And then nodule is going to be the second most common one. You also have lentigo maligna, acrolentiginous. I mean, you have different types. You even have subungual. This is the one that's found on the thumb and the toe. This is usually those patients that come in and you see that black line, right? It looks like they have like a natural nail painting done, but it's not. That's cancer. So usually with their sublingual, usually they have a history of trauma. It's going to be a macule at the beginning of the nail matrix. It's usually going to be super long like that, and it's dark. And usually these patients are going to have dystrophy of the nail, and they'll have a nail bed plate involvement. And just diagnosis in general for melanoma is going to be total excisional biopsy. But of course, we don't do this on areas that are cosmetically sensitive. So we're not going to do this on the face. So it's just going to be in areas that are not cosmetically sensitive. And we can also do an incisional or punch biopsy. And some of the red flags, if it's blue, that means it's more deeper, which makes sense, right? Because whenever we think about the vessels, blue, it's more deeper, so it's going to be a red flag. So these patients, we're going to refer them for dermatology. We're going to follow up with them every 6 months for 2 years, and then after that, annual follow-up. Ensuring that we educate these patients again, once again, for protecting their skin against the sun, ensuring that they do self-exams. These have a very high risk of recurrence, so usually they get adjuvant therapy also. And prognosis, they have a high cure rate if they're diagnosed and they're treated early. And usually the key factors and whether this is going to be good or not, or has a good prognosis, is how thick is the lesion, how deep is it, and how much has it invaded. So Fitzpatrick scale is something that they really like to ask. So I'm just going to go over it real quick because it can help you in regards to just trying to identify what patients are at risk for skin cancer, and it's usually going to be the patients with fairer skin. So usually with Fitzpatrick scale, it's going to be a patient that has very fair skin. That's going to be 1. It's going to be a patient that always burns, but they cannot tan. So it's going to be 1. 2 is going to be a patient that is fair skinned. They usually burn, but sometimes tan. Fitzpatrick scale 3 is going to be a medium skin patient. They sometimes burn, but they usually tan. Fitzpatrick scale 4 is going to be usually an olive skin. They rarely burn and they always tan. Fitzpatrick scale 5 is going to be brown. They rarely burn, but they tan easily. And Fitzpatrick 6, it's going to be dark brown. They never burn, they always tan. So the patients that we think about, right, in regards to that are at risk for getting your cancers, for skin cancers, are usually your patients are 1 and 2, right, even 3 sometimes. Patients with very fair skin, fair and even medium skin, but by far the common ones 1 and 2 for Fitzpatrick scale. So the next one's going to be Kaposi sarcoma, multifocal systemic tumor of the endothelial origin. This one has 4 variants, and it involves systemic involvement because it can involve the GI and the lung. Most commonly involves the GI and the lung. And usually when we think about Kaposi sarcoma, usually we think about patients that are immunosuppressed, right? We think about our patients with HIV and AIDS, especially when the HIV and AIDS epidemic occurred, right, in the 1980s. We had a lot of patients coming in with full-blown Kaposi sarcoma. So some of the etiologies, like we discussed, HIV, also human herpes virus, type 8 infection, B-cell lymphoma, immunocompromised, transplant patients, AIDS patients, so any patient that is immunocompromised. This patient is going to be presenting mucocutaneous ulcerate and bleeding easily, pain. They'll have urethral and anal obstruction. And like we said, this involves the GI and the lung. So they're going to be presenting with GI obstruction or bleeding, bronchospasms, once again, because it involves the lungs. So they're going to be presenting with intractable coughing, shortness of breath, respiratory failure. And how is this going to start? It's going to start as an oval ecchymotic macule. It's going to occur at the site of trauma, parallel to skin tension lines, and it's going to evolve into patches, papules, plaques, nodules, and tumors. You'll see a green halo, and you'll also see lymphedema, erosion, and ulceration. This one, the color is going to be purple and red. So first manifestation is usually going to be an oral lesion. It's usually very commonly found on the hard palate. And then it's going to start at the feet, legs, and hands, and then it's going to slowly spread centripetally. So once again, it's going to start on the feet, legs, and hands, and then slowly spread centripetally. Diagnosis is going to be a skin biopsy. We also image these patients just to see if they have any type of internal organ involvement. Treatment's going to be cryosurgery, laser surgery, photodynamic therapy, electrocautery, excisional, radiation, systemic chemotherapy, and our goal in general is just to control the disease, right? And control the disease, control the symptoms of the disease. So now that we're done with that one, let's go into Papulosquamous, alopecia, pigmentations, and other disorders. So let's go into irritant contact dermatitis. This is usually due to a chemical irritant. It occurs after a single exposure to an offending agent which is toxic to the skin. It's the most common type of occupational skin disease. Usually the patient's going to have a history of, for example, using certain cleaning agents or abrasives, oxidizing agents, reducing agents, plants, animal enzymes, powders, dust, soil. All these things can make a patient prone and can make a patient get irritant contact dermatitis. Also excessive exposure to water. So how do we differentiate this one, allergic contact dermatitis, to irritant contact dermatitis? So irritant contact dermatitis is usually going to be a patient that has exposure to something topically that is causing that. Versus allergic contact dermatitis, it's going to be something that the patient ate that caused that allergic contact dermatitis, or something that the patient even wore. They have to come in contact with something. So irritant contact dermatitis, like we discussed, there's going to be things that are going to predispose a patient to getting this. So some of the predisposing factors can be atopy, fair skin, low humidity, occlusion, or some type of mechanical irritation. Also, what's the occupation of the patient? We think about, for example, medical, we're constantly washing our hands, we're constantly using those hand sanitizers, dentists, veterinarians, housekeeping, since we're dealing a lot with the chemicals, right? Clorox, hairdressers, once again, those chemicals on the head, floral, agriculture, forestry, food preparation, printing, painting, metalwork, engineering, cart maintenance. I got a lot of mechanics during my family medicine rotation that would come in with irritant contact dermatitis, construction, fishing, and this patient can present with both acute symptoms and also with chronic symptoms. So usually when we think about our acute symptoms, it's usually localized to the confined area that's exposed. It's most commonly found in the hands. The patient is going to be complaining that it's burning, it's stinging, smarting, and sometimes this can be either an immediate reaction or a delayed reaction, like more than 24 hours. You're going to see erythema, vesiculation, caustic burn with necrosis, sharply demarcated superficial edema. And the thing about this one is that lesions do not spread beyond the site of contact. So it's just going to be localized in that area where there was contact. Severe irritant contact dermatitis, this is where the patient has vesicles, blisters, right? Erosions. It can even have necrosis. Now, what about chronic symptoms? So these are actually the symptoms that you're most commonly going to see. And usually what happens is that this patient starts developing these symptoms because they're chronically having exposures to whatever is causing this. So it's going to be due to repeated exposures. And it develops slowly, usually on the hands like we discussed because we use our hands a lot. The patient's going to have a stinging, smarting, burning, itching, pain with fissures, dryness, chapping, erythema, and that's a key word for this one, right? Hyperkeratosis, those chapping, those fissures, that dryness. You'll see ill-defined borders, lichenification. Whenever I think about lichenification, it's something that's been going on for a while, right? It's going to start in the finger web spaces, then on the sides and dorsal surfaces, then on the palms. For housewives, it's going to start on the fingertips. Diagnosis, we can do a patch test, but it's going to be negative, right? Because this is going to be due to an irritant on the skin, not something that's coming in from the inside. Treatment for this is usually for these patients, if it's on the hands, we can do something like topical therapy where they soak their hands in. If it's an acute irritant contact dermatitis, the first thing in general for both acute, subacute, and chronic irritant contact dermatitis is what? Removing the offending objects. So whatever is causing this patient to keep getting this, stop doing it. Sometimes they even need to change jobs, right? If the patient is a house cleaner, maybe do something else. You know, sometimes it's really hard for the patient, but maybe changing jobs, that way they're not repeatedly injuring their hands or having contact with these chemicals. So acute, you can do something like wet dressings, topical corticosteroids also. If it's severe, then you can do oral steroids or emollients. Subacute and chronic, you're going to do potent topical corticosteroids, lubrication also. And then prevention, like we said, avoid the irritant. Protective clothing, wear gloves, barrier creams. Next one's going to be allergic contact dermatitis. This is going to be due to an antigen or an allergen that elicits what type of hypersensitivity reaction. This is something that's very commonly tested. So it's going to be a type 4 hypersensitivity reaction for these patients. And this is usually going to be dependent on sensitization, and it only occurs in sensitized individuals. It's common in all ages, but of course, elderly and children, not very common, but aside from that, it's found in all ages. This patient is going to be presenting with an eczematous dermatitis. It's going to be very, very itchy, and that's how you can kind of differentiate it from irritant contact dermatitis, is that you don't have that hypersensitivity that is causing all the itchiness. So with allergic contact dermatitis, it's going to be very, very itchy versus irritant contact dermatitis. Usually it's not itchy for these patients. It's more painful than anything. So this patient is going to be presenting with allergic contact dermatitis, intense pruritus, stinging pain. They can also have acute illness syndrome, right? So those fevers, body aches. And initially it's going to be confined to the area and then it's going to spread. Versus irritant contact dermatitis is usually confined to that area. Allergic contact dermatitis, it'll start confined, but then it's going to start spreading. And it can be either isolated or generalized. But like we said, this patient has to come in contact with something in order to cause that. So once again, with allergic contact dermatitis, we have acute, chronic, and subacute. With acute, it's going to be a well-demarcated erythema or edema. With these patients, you can also see non-umbilicated vesicles, and they're going to have erythema, papules, vesicle erosions, crust, and scaling. For subacute, there's going to be plaques of mild erythema, small dry scales, small red pointed firm erythematous firm papules and scales. For chronic, lichenifications, remember I discussed I usually think for lichenification in regards to these for anything that's been going on that's chronic. So lichenification for chronic allergic contact dermatitis, thick scaling with satellite, small firm, rounded flat top papules, excoriations, and pigmentation. So diagnosis, this is where we're going to do a patch test. So what's a patch test? We're going to apply an allergen to the skin, and it's going to be positive on every part of the body for these patients. So they're going to have erythema, papules, and vesicles. Treatment is just for everything, avoiding whatever is causing it. Wet dressing, you can also do topical corticosteroids, usually class 1 through class 3. If they have acute flare-up, then you can do systemic steroids for these patients, right? So, atopic dermatitis is going to be the next one. So, atopic dermatitis is usually acute, subacute, or chronic relapse in skin disorder. It's usually a very pruritic inflammatory skin disease. Very common in infancy, specifically during the first 2 months to the first years of a patient's life. And usually they're going to have a family history of atopic dermatitis. And then on top of that, they're going to have a family history of a lot of allergies. We think about our triad, right, for atopic dermatitis. So we think about atopic dermatitis, allergies, and asthma. We think about those triads. And usually when I'm reading a question stem and the patient has a history of allergies, they have asthma, and they're presenting with something in regards to their skin, I think about atopic dermatitis. So just think about that triad, and it should really help you out on the exam. So what happens is that they have some type of skin barrier dysfunction. So they have an impaired flagellin production. They have reduced ceramide, water loss, and dehydration of the skin. And they have IgE reactivity. It's most commonly found in males and females, and there's a genetic aspect to atopic dermatitis. So there's certain factors that can predispose a patient to this, like inhalants, like dust mites, pollens, infections like Staph aureus, group A strep, candidiasis, even autoallergens like IgE antibodies, foods even, egg, milk, peanuts, soy fish, wheat, seasons, like patients will get the winter flare, clothing after taking off their clothing, especially if they're wearing clothing that contains wool, and then also stress. So how is this patient going to present? If they're going to have dry skin, it's going to be very itchy. Why? Because once again, it's a type of hypersensitivity problem. Rubbing, they're going to have increased inflammation and lichenification because they have that itch and scratch cycle. It's itchy, they scratch, itch, scratch, rash, itch, scratch, rash. So this patient is also going to be presenting with allergies, like we said. They can have obstruction of nasal passage, conjunctival and pharyngeal itching and lacrimation, and it's usually seasonal with pollen. And the thing about this one is that it's going to be found on the flexor area. So flexor surfaces, atopic dermatitis, we think about the antecubital fossa, right? Versus things like psoriasis, right? Psoriasis is usually found on the extensors, like we think about the elbows. Extensors is going to be your atopic dermatitis. And that's how I kind of memorize this one, is anywhere that's an extensor. And usually we think about our antecubital fossa, that's where you can find your atopic dermatitis. So flexor surfaces, they can also be found on the front or side of the neck, the eyelids, the forehead, the face, the wrists, the dorsum of the feet and hands. If they have a severe case of atopic dermatitis, then it's going to be generalized. So for an acute case of atopic dermatitis, you're going to see poorly defined erythematous papules or papules or plaques with or without scaling. Edema, it's usually going to be a very puffy skin. Erosions due to scratching. And these patients are very prone, once again, to getting secondary infections. Why? Because it's that itching and scratching. You're doing trauma to the skin, so you have infections and bacteria that can invade that traumatized epidermis and can cause infection, right? So usually if they do have secondary infections, you're going to see oozing erosions, you'll see pustules, the skin's going to be very dry, cracked, and scaly. Once again, when we think about chronic atopic dermatitis, the keyword, right, lichenification. You're going to see follicular lichenification, fissures that are very painful. The patient can also present with lateral 1/3 of the eyebrow alopecia, periorbital pigmentation. And think about atopic dermatitis, right? It's exacerbated by stress and sweating. So if the patient sweats, it can be worse. Diagnosis and clinical, we want to make sure that we work these patients up for allergies because it's very commonly associated. Remember the atopic triad, right? Which is going to be atopic dermatitis, your allergies, and your asthma. So just work up these patients for allergies, complications like we discussed, secondary infections, uh, and then just make sure that we educate the patient on avoiding scrubbing that area and rubbing. I know for children it's very itchy and this is usually impossible. So usually we do give them things like wet dressings or emollients, hydroxyzine, right, for your pruritus. First line is going to be your topical corticosteroids for atopic dermatitis. Next one's going to be lichen simplex chronicus. This, how it sounds, right? Lichen simplex chronicus. And usually it's due to repetitive rubbing and scratching of the same location. So it's very, very itchy. They scratch it and they're constantly rubbing, and that's what causes this lichenification. So remember, we discussed anything that's chronic, lichenification. I know I've said this so many times, but repetition is a key. And the thing about this one, it's very commonly found in the back of the neck. So in the back of the neck, it's going to be like very lichenified, and they're constantly scratching that area because it's really, really itchy, because it feels better whenever they scratch it. So most commonly found in women, especially if they're older than 20 years old. And usually stress is what causes it. And like we discussed, the nuchal area, like the back of the neck, is very common for these patients, and that's how it's going to present on their question stems, especially in females. But it can also be found on the scalp. It can be found on the ankles, the lower legs, the upper thighs, the forearms, even the vulva, the anal area, the scrotum, and the groin. This patient's going to be presenting with pruritus, so paroxysms of it's like itchy, thickened skin, what you're going to see on your physical exam, skin markings, accentuated excoriation, and treatments. Just, you want to make sure you get the patient out of the habit of scratching that area and rubbing that area. So you're going to do something like occlusive bandages, topical corticosteroids also, and you can also give them something like hydroxyzine just to quit the itching. So the next one's going to be your dyshydrotic eczematous dermatitis. So this is a special type of hand and foot dermatitis. Thing about this one is that it can be acute, subacute, or recurrent. And this patient is going to be presenting with pruritus. It's going to be painful whenever it's erosive. And the keyword for this one is going to be your clear tapioca-like vesicles. So once again, clear tapioca-like vesicles, you're thinking about dyshydrotic eczematous dermatitis. You're also going to see for these patients large bulla, scaling fissures, lichenification, and the sites are usually going to be the fingers, the palms, and the soles. And once again, these patients are very prone to getting secondary infections. Why? Because you have trauma to that barrier of the skin. So they're very prone to getting pustular cellulitis, lymphangitis, and treatment for just dyshydrotic eczematous dermatitis is going to be topical corticosteroids, and they're going to be high potency. If they have a severe case, then we're going to give them prednisone, and then of course make sure that we taper this, and oral antibiotics for secondary infections. So once again, dyshydrotic eczematous dermatitis, it's going to be that clear tapioca-like vesicle that can be found in the fingers, the palms, and the soles. In the question stem, it's going to be very commonly found on the soles. And treatment's going to be topical corticosteroids, high potency topical corticosteroids. Next one's going to be astiotic dermatitis. This is commonly found in elderly, especially during the winter. It's going to be a patient with a history that they bathe a lot, so they like those hot, soapy bath showers. They're going to be presenting with a lot of itchiness, and the thing about this one is that it can lead to lichenification, right? Why? Because it's itchy. You're constantly putting trauma in that area. It's going to be dry, cracked, superficially fissured skin with slight scaling. The areas are going to be the legs, arms, hands, and trunk. I actually had a question for my NCCPA practice exam, I think, on this one. And it was an older patient that she presented during the winter, and I missed it. So just make sure you are familiar with astiotic dermatitis, right? Elderly, winter, frequent breathing, itchy, lichenification, cracked area, right? Legs, arms, hands, trunk, and just treatment for this, educate the patient to avoid overbathing, right? Avoid getting that trauma on the skin, humidifiers, emollients, and then you can also do medium potency topical corticosteroids if there's a lot of inflammation going on. All right, next one's going to be psoriasis. This one is very common. One of your Famous people that has this, interestingly, is Kim Kardashian, which I didn't know. I was going over a flashcard the other day and I saw that she was on there, so I thought that was pretty interesting. So psoriasis, this is very common. It's a chronic inflammatory multi-system that usually involves the skin and joints. It waxes and wanes during the patient's life. So the onset, there's two peaks. So it peaks at the ages between 20 to 30, and then later in life between 50 and 60. Usually these patients have a very strong genetic component, usually due to cytokines that are released by immune cells. And there's certain triggers that can make a patient into relapsing into getting psoriasis, right? So things like bacterial infections like streptococcus, right? Trauma, rubbing and scratching the area, drugs, systemic steroids, stress, alcohol. And usually these patients are going to be presenting with a plaque. So the plaque is usually going to be found in the knees, elbows, low back, ears, scalp, umbilicus, gluteal, cleft, and nails. And there's different types of psoriasis, but by far plaque is going to be the most common form. And this one changes very slowly. It's associated with the Auschwitz sign, right? And it's also associated with the Keebner phenomenon. The keyword for this one's going to be red plaques that are surrounded by white silvery scales. They're loosely adherent, they're sore, and they're typically symmetric and bilateral. They're very, very itchy. And usually for these plaque treatments, going to be with PUVA or systemic treatment that is either given monotherapy combined or rotational therapy. And like we discussed with psoriasis, it's going to be very commonly found where on the extensors, right? On the extensors. You also have your guttate psoriasis. This is usually found in the trunk, extremities, and face. This has acute onset. It's the size of a raindrop. It's usually a scaly papule or plaque. It's salmon pink with or without scales. And also this one's going to be a positive Auschwitz sign. Usually this is commonly associated after a patient has some type of group A strep infection. Treatment of this, of course, is treating the group A strep infection with antibiotics, but you can also do narrowband UVB irradiation. All right, guys. So diagnosis in general for psoriasis is going to be a clinical diagnosis for these patients. Treatment, like we discussed, systemic glucocorticoids, ionizing radiation, photochemotherapy like PUVA. You can also do cyclosporine and methotrexate. If it's limited, if they don't have a limited area with psoriasis, then with these patients, we treat them with topical corticosteroids. That's going to be usually the first line. So if it's limited, like it has less than 5% body surface area, first line is going to be topical corticosteroids, and it's going to be the potent topical corticosteroids. If it's extensive, they have it in multiple areas, just not, for example, in the elbows, but they have it in the elbows, the face, like everywhere, then these patients get systemic methotrexate, right? And with these patients, if it's on the palms or the soles, they get occlusive dressing plus class 1 topical corticosteroids. If it's on the nails, they get topical treatment. If it's generalized plaque type, like we discussed, usually these patients get phototherapy, they get oral retinoids, they can also get methotrexate. If it's psoriatic arthritis, we have to make sure that these patients, we recognize it earlier and we treat them as soon as we can because we want to prevent it from destroying the bone. So usually these patients get methotrexate. So once again, the thing about psoriasis, like we discussed, plaque is going to be the most common type. Usually we're going to be found on your extensors, like we discussed, the elbows. That's usually where I commonly see it on the exams and on the knees. And with these patients, you're going to see that red plaque that's surrounded by a white silvery scale. They're going to have a positive Auschwitz sign, and they're going to have a Keebner phenomenon with these patients. And like we said, treatment is really going to be dependent on whether it's localized or if it's extensive. If it's usually localized for these patients, or if it's limited, it's usually going to be topical corticosteroids, which are going to be your potent topical corticosteroids. If it's extensive, then that's when we go into methotrexate. So just in general, right, all types of psoriasis get topical corticosteroids, and just educating the patients on the side effects of topical corticosteroids like skin atrophy, hypopigmentation, right, striae. Why? Because you're damaging that skin. All right, so the next one's going to be lichen planus. So lichen planus is either can be acute or chronic, and it involves skin and or the mucous membranes. This one can persist for months or years. And if it's hypertrophic lichen planus, then it can persist for decades. Very commonly found in females and also between the ages of 30 to 60. This one's going to be flat, topped, pink to violaceous, shiny, pruritic, polygonal papule. This is where we think about the 4 P's, right? Papule, purple, polygonal, pruritic, and plateau. You also have your Wickham striae with this one, which is going to be those white gray lines. It's going to be grouped, annular, and disseminated. Now, where are the sites where lichen planus is found? Usually on the flexors aspects of the arms and legs, the wrist, the lumbar region, the chin, the scalp, the glans, penis, the lips, and these patients are also going to have Keebner phenomenon. It can be found in the mouth, and usually with the mouth, we're going to see those milky white reticulated papules that can become erosive and painful. So that's a key for this one. If you see anything with the mouth involvement, anything that's like white reticulated papules, I think about lichen planus, right? We think about those Wickham striae. And usually with these patients, treatment's going to be usually local, so topical corticosteroids with occlusion. We can also do something like intralesional triamcinolone, right? Tacrolimus solutions like that mouthwash for these patients that have that Wickham striae. You can also give them systemic treatment like cyclosporin or corticoids, but usually if it's just local topical corticosteroids, if it's systemic, they have it everywhere, then we can do something like cyclosporin or oral glucocorticoids. Next one's going to be pityriasis rosea. This is going to be an exanthematous eruption that mainly occurs in young people. The age is going to be between 10 to 35, and it tends to occur very commonly during the spring and fall. Usually these patients are asymptomatic. If they do present with symptoms, they can present with symptoms of flu, malaise, nausea, loss of appetite, GI upset, upper respiratory symptoms, fever, swollen lymph nodes, and sore throat. And the thing about pityriasis rosea, and this one's very commonly tested, and what you need to know is that usually this patient's going to say in the question stem that they started with one lesion. And it's usually the Herald patch, which is going to be an annular erythematous patch with peripheral scaling and central clearing. So it's going to be, they started once, oh yeah, a few days ago, a few weeks ago, he started with one lesion, now it's like all over their back. And that's usually how it's going to present on the question stem. And usually it's going to be that Christmas tree eruption because it's going to literally look like a Christmas tree on the trunk or on the back of the patient. So treatment for this, it's self-limited 5 weeks. Just make sure that we educate the patient, right? Reassurance, because it's going to go away by itself. It's going to take weeks to go away, but it's going to go away by itself. Usually 5 weeks. And that's how I've also seen this question asked, is that what you want to educate this patient is that just make sure they're drinking a lot of fluids and expect the rash to go away in 5 weeks. So you can give them certain medications, like you can give them something like oral over-the-counter anti-itch creams, topical corticosteroids, or oral antihistamines for these patients, but usually they go away with these patients. So with pityriasis rosea, we really don't know what the cause is, but we suspect that it's associated with human herpes virus 6 and 7. So you may be asked about this, so just make sure that you know that also. So the next one's going to be melasma / chloasma. So this is going to be a well-demarcated macular light to dark brown hyperpigmentation of the face. Etiology is more commonly found in females. It runs in the families, most commonly found in darker skin types. And it's usually associated with hormonal changes, right? We usually think about mask of pregnancy. So it's usually going to be a patient that's pregnant, they're on type of oral contraceptives, hormonal replacement therapy, and the cause is really idiopathic. So with these patients, symptoms, it's usually going to be found on the frontal areas, uniform or blotchy for these patients. It's worse with exposure to UV light. And just treatment, just educating the patient, right? Avoid the sun. Use sunscreen. If the patient does want to remove it, it's usually for cosmetic purposes. So you can give the patient triple topical therapy, lasers, and even chemical peels. The next one's going to be your vitiligo. This is going to be a well-circumscribed depigmented macule and patches. It can enlarge gradually. Usually it's autoimmune attacks on the melanocytes, and usually these patients are going to have a genetic component to it, most commonly found during the ages of 10 to 30. and usually they're going to have a rapid onset with a period of stability or slow progression. In regards to symptoms, it tends to favor the areas of trauma, so usually commonly found on your knees, your elbows, fingers, mouth, eyes, genitalia, and usually these patients are going to have that Keebler phenomenon, right? They can even have white hair. So diagnostic is that we'll do a Woods light exam just to differentiate between hypopigmentation and depigmented lesions. Treatment's going to be potent topical corticosteroids. We can also do topical tacrolimus, right? The next one's going to be pemphigus vulgaris. So the key to this one is differentiating between pemphigus vulgaris and bullous pemphigoid because they're very similar. But the key to differentiating between these two is the patient population, who it presents with, and how it presents. Which one is severe, right? Which one has a flaccid bulla? Which one has a tense, intact bulla? So how I think about this is pemphigus vulgaris has a V in it, so I think about villain, right? Pemphigus vulgaris, villainous. So pemphigus vulgaris is more severe than bullous pemphigoid. Okay, so since it's going to be more severe, it's going to have that flaccid bulla, right? That you press on it and it just falls apart. So let's go into it. Pemphigus vulgaris, V for villain. This is where there's autoantibodies to desmogleins that result in superficial bulla and erosions. This one is fatal. It's very commonly found in adults between the ages of 40 to 60. And usually with these patients, they're going to have flaccid blisters, once again, on the skin. They easily erupt, and these are going to be positive Nikolsky sites. So once again, it's going to be those flaccid bulla, those flaccid blisters in comparison to bullous pemphigoid, which is going to be that tense bulla, right? So pemphigus vulgaris, that flaccid bulla. So usually with these patients, they're also going to be presenting with erosions on the mucous membrane. They're going to be very painful, burning. They're going to be bleeding easily, vesicles. They're going to have serous content also. And the areas involved are going to be the scalp, the face, the chest, the axilla, the groin, the umbilicus, and even the back if the patient is bedridden. These patients, we're going to consult dermatology, we're going to do a biopsy, and we're going to diagnose with direct immunofluorescence. And like I said, in the burn center when I was there, these patients got biopsy also. So treatment is just fluid and electrolyte imbalances. We can do oral steroids and immunosuppressions. So that's going to be pemphigus vulgaris, right? It's going to be your bulla that is flaccid. You press on it and it's going to fall apart. It's going to be that positive Nikolsky sign. Versus bullous pemphigoid, this is going to be autoantibodies of parts of the hemidesmons that result in deep, tense bulla. So once again, this is going to be a tense, firm bulla. It's going to be intact. And these are usually going to be found in older adults. So in pemphigus vulgaris, it's going to be your younger adults, 40 to 60 years old, versus your bullous pemphigoid. Usually in the question stem, it's going to be patients in their 70s or 80s. And that's how you can differentiate between these two in the question stems if you're lost in the description. So bullous pemphigoid is going to be your older patients, 70s, 80s, versus pemphigus vulgaris. It'll be your patients that are in their 40s, 50s, and 60s. So bullous pemphigoid, the areas that are going to be commonly associated are going to be the axilla, medial thigh, the groin, the abdomen, the flexural surfaces, the lower extremities, the mouth. They're going to be presenting with a pruritic, papular, or urticarial lesion with bulla. They're going to have a prodrome of pruritic, urticaria, and papular tender bulla. It's going to be oozing, bleeding. Diagnosis is going to be your direct immunofluorescence. We're going to refer these patients to dermatology. They're going to have prednisone and or topical corticosteroids. So once again, bullous pemphigoid, tense from bulla. Usually it's going to be your older patients, 70 and 80s, versus pemphigus vulgaris. This is an emergency. Positive Nikolsky sign. These are going to be those bulla that are flaccid, and usually it's going to be found in your patients that are younger. Next one's going to be alopecia. This is going to be an autoimmune attack on hair follicles by lymphocytes. Hairs falls out literally in patches, and it can occur on any area of the body that there is hair. There's a really good anime. It's called Cells at Work. I really recommend it. And they have an episode on alopecia, and it's basically how your body works. And it's anime, there's people that are working in your body, and there's an episode on alopecia where there's hair follicles, which are people, and with these patients, he's having alopecia, and you see those poor hair follicles just being destroyed by the T cells. And T cells are like these huge, like muscular people. They're just like taken over, right? Because they're just like zombies, and they're killing all the poor hair follicles. And then you have the steroids that come in and they treat the patient. So it's really good. I really recommend that if you're a visual person. I'm a huge visual person, so that episode was amazing and I highly recommend it. So it's Cells at Work. That's the anime. So in regards to alopecia, it's an autoimmune disorder, and usually these patients are going to have a history of an autoimmune problems, right? So they'll have thyroiditis, Down syndrome, very commonly found in your young adults less than the age of 25, and recurrences are frequent. On usually for these patients, what you're going to see is localized round, oval to no inflammation hair follicle that's going to be intact. It can regrow. This one's non-scarring. Usually they're going to have a solitary patch, follicular openings present. And the keyword for this one is going to be those exclamation hair marks, right? Exclamation hair marks are going to be scattered, discrete areas. And if it's diffuse, usually they have an appearance of thinning hair. So once again, keyword for this one is going to be exclamation mark hairs on your physical exam for alopecia. So diagnosis, we want to make sure that we diagnose the patient and look out for any other type of autoimmune disorder. So we're going to do an ANA for lupus. We can do an RPR just to rule out syphilis, and then KOH just to rule out tinea capitis, right, which is the fungal infection of the head. Treatment is usually it resolves without treatment in 6 months. If there's a large area involved, they have a very poor prognosis. So these patients, we refer them to dermatology. If we do give them medications, we can give them something like potent topical corticosteroids, even topical minoxidil. So the next one's going to be tinea capitis. So I had a question on the PANCE in regards to tinea capitis and alopecia. So make sure that you know the difference between both of them. So alopecia, right, is exclamation marks on the head. It's an autoimmune disorder, and treatment for this is going to be topical corticosteroids versus tinea capitis. This is a fungal infection on the head. So treatment for this is going to be with your antifungals. So make sure you know the difference between these two. Tinea capitis, right, scalp hair traps fungi. And what happens is that there's some type of trauma, right? Once again, that trauma to that epidermis of the hair that is going to help with inoculation. So you have dermatophytes that invade the scalp. They spread to other hair follicles, and usually this tends to occur in your younger patients. You're usually your toddlers, school-age children. And it's transmitted from person to person, animal to person, fomites. And usually what you're going to see is you're going to see non-inflammatory scaling and broken off hairs, right? Scaling and broken off hairs versus alopecia, you're going to see those exclamation hair marks. So once again, exclamation hair marks, alopecia versus tinea capitis is going to be your scaling and broken off hairs. You're also going to see severe, painful, inflammatory, boggy nodules that drain pus. That's another keyword that I've seen on your exams. Severe, painful inflammation and boggy nodules that drain pus. This one can be scarring. And there's ectothrix, which occurs outside the hair shaft with these patients, where there's hyphae that fragment into anthroconidia that lead to cuticle destruction. There's endothrix, that's when it occurs inside or within the hair shaft without cuticle destruction. And this is where you have that arthroconidia that is found within the hair shaft. These patients can also present with a black dot, which is a variant of the endothrix resembling seborrheic dermatitis. Also, the patient can have a curion. This is a variant of the endothrix with boggy inflammatory plaques. So usually with the curion, you're going to see an inflammatory mass, boggy, purulent nodules, plaques. This one looks really gross. Painful, there's a lot of pus, hair's like falling out, and the patient's like pulling out because it's just really, really painful. They can also even have sinus formations on their scalp, thick crusting. They can also have matting hairs, lymphadenopathy, and this one's going to heal with scarring. And these patients, we refer them, right? And usually we'll give oral prednisolone with antifungals. So just in general for tinea capitis, we're going to diagnose them by doing a Wood's lamp. We're going to do a direct microscopy, and that's where we're going to see scales with hyphae and arthrospores. We're going to do a fungal culture. And treatment's just going to be based off the fungal culture, right? So we want to make sure that we culture of the patient, the culture of the infection that is causing it. And treatment for this is going to be usually griseofulvin, right? Griseofulvin for children, and then we can also do terbinafine for these patients, but usually it's going to be oral griseofulvin. So these don't get topical. So remember when we were talking about all the tinea ones, they usually get topical antifungals. The only ones that get oral are going to be what? Your nail infections, right? And then also your scalp infections like tinea capitis. So onychomycosis, right? The nail infection gets oral antifungals like terbinafine. So does tinea capitis, which is the infection of the head, which is going to be oral griseofulvin. So once again, alopecia, right? Those exclamation marks on your physical exam, exclamation mark hairs. This is an autoimmune disorder where the own body is attacking the hair follicles versus tinea capitis. This is a fungal infection of the head. And with these patients, you're going to see scaling and broken off hairs, boggy nodules, painful inflammation. You'll see pus in these patients, and treatment is going to be with good oral griseofulvin. And then just make sure that you're educated on these patients that if they have this, prevent the spread. Don't share towels, brushes, or hair accessories. So, all right then, let's go on to the next one. And then usually the griseofulvin treatment for these patients are usually for 8 weeks. So griseofulvin, 8 weeks. And since it's very commonly found in children, griseofulvin is usually given for children. Terbinafine is usually not available in children's formulation, so that's why we tend to give griseofulvin. So the next one we're going to go into is going to be skin integrity, urticaria, and then some other skin disorders. So let's go into burns. So burns, I did a whole rotation in burns. I was there for 3 to 4 months during that rotation, and I have to say it was a huge learning curve. I definitely learned a lot. In PA school, I only had 1 lecture on burns, and it was probably like an hour, and that was it. And I rotated there for 3 to 4 months, so I learned a lot in regards to burns. And burns is something that they really like to test you on, so you have to make sure that you are comfortable with calculating body surface area of how much the body of a patient is affected, especially adults. I don't think I've ever had a question for children, because remember, children have bigger heads in comparison to their bodies, so you use a completely different type of body surface area in regards to children. But for adults, this one's very commonly tested, so it's really important that you know to calculate the body surface area. So burns, it's an acute wound due to isolated non-reoccurring insult, and they progress rapidly through orderly series of healing steps. So cells are destroyed. And the thing about burns and how to classify each one is depending on what part of the skin is involved, right? So remember when we were talking earlier about cellulitis, we have the different types of portions of the skin. So when we think about burns, we have our epidermis, which is going to be our top layer. We have our dermis. Usually our dermis we think about involving parts of our sebaceous glands, hair follicles, and then you keep going deeper. That's where you have like the subcutaneous tissue, right? And then you keep getting deeper, and then that's when you're going to have things like your muscle and your bone. So the burns are really going to depend on how many layers of your skin you go through and how deep is that burn, and that's going to tell you whether it is your superficial burns, your partial thickness burns, your deep partial thickness burns, or your full thickness burns. The old terminology for burns was 1st degree, 2nd degree, 3rd degree, and 4th degree. We are actually getting away from those, and in the burn center when we were there, we just referred to them as superficial. Of course, we never had patients that presented with superficial, but we are referring to them as partial thickness burns, deep partial thickness burns, and then our full thickness burns. We're getting away from that terminology, but just for textbook wise and the PANCE, I'm not sure which one they're using. From what I was, and I just recently took my exam when I was studying, for me it was more the practice questions that I was doing was more the new terminology, which was your the ones that we discussed: superficial, partial, deep partial, and then thickness and full thickness. But I'll go over both of them. So with these patients, like we discussed, what is each one? So superficial is usually involves the epidermis only. So it's going to be the first layer of the skin, right? So since it only involves the first layer of the skin, you haven't gone through the dermis, which involves your sebaceous glands, which has your nerves, right? Which has your um, your nerves, it has your hair follicles. So it's only the epidermis, which is the top, right? So that's going to be your superficial. So this patient is going to have no blisters. It's going to be very painful. Why is it going to be very painful? Because it has not gone through the nerve yet. So it only involves the epidermis. So that's why it's very painful, because that nerve is intact. It's going to be dry, red, blanch. Why is it going to be dry? Because it's only the epidermis that hasn't gone through that sebaceous gland. It's going to be blanching, and usually these peel after healing and there's no scarring. Usually the most common when we think about superficial burns is going to be your burns that you get from the sun, right? Your sunburns or superficial burns. So once again, superficial burns, epidermis only, no blisters, painful, dry, red, blanched. They peel after healing and these have no scarring. So first degree burns is also known as your superficial burns. Second degree burns, aka your partial thickness burns, involve two types of burns. It involves your superficial or partial thickness burns and then your deep partial thickness burns. So once again, these are going to be your second degree and or partial thickness burns, which are going to be your regular partial thickness burns, or your deep partial thickness burns, or your superficial partial thickness burns. In the burn center, we just call them partial thickness burns, and then your deep partial thickness burns. So for your second degree or these partial thickness burns, what they involved is the epidermis, but they also involve part of the dermis. So they haven't gone through the entire dermis, they've only gone through part of the dermis. So these patients are going to be presenting depending on whether it's partial thickness or deep partial. So partial thickness burns is going to be blisters. This one's going to be very painful. Why? Because once again, they have not gone through that nerve. They're going to be blisters. They're going to be red, weeping, blanching still, and usually scarring is unusual for these patients. They tend to heal between 7 to 20 days. Deep partial thickness, this is where you actually went through the deeper portion of the dermis. So you've gone through the entire epidermis, you destroyed the epidermis, and then you've gone through like the very deep portions of the dermis. So usually there's going to be damage to hair follicles, glandular issues. This one's going to be also painful to pressure. It's going to be blistering, and it's going to be wet, waxy, dry, patchy white to red, and this one does not blanch with pressure. And that's a key with this one, right? It does not blanch with pressure. So the key for deep partial thickness is that it's going to be blistering, it's going to be waxy, patchy white, and it's going to be does not blanch with pressure. And this one heals, it takes more than 21 days to heal. The next one's going to be your third degree or your full thickness burns. This one involves all of the dermis, all of the epidermis, and also involves the subcutaneous. So you burn through all the nerves, you burn through your sebaceous gland, you burn through your follicles. So with these patients, you're usually going to have a burn eschar. It's going to be a dead denatured dermis. It's usually going to be intact, and this one rarely heals. And this one's not going to be painful at all. So I would have these patients where you would rub on it, and it was not painful whatsoever with these patients. And this one's dry, like dry, really dry. Why? Because you burn through that sebaceous gland. And that's how you should think about it, and that's how it's going to help you in your exams. Think about what have they burned through? What does that skin dermal layer contain? So full thickness, right? They burn through all the epidermis, they burn through that dermis, even the subcutaneous tissue. You want to see a hair follicle. The sebaceous gland is burned, so it's going to be dry, right? With these patients, like we said, it's not going to be painful at all. You can rub all you want on it, and it's not going to be painful. Versus like your partial thickness, like your partial thickness burns, these are very painful because you keep going back and forth, and these are super painful. So with these patients, we also have a fourth degree, which is very, very deep. We rarely ever saw these in the hospital because when these patients came in, they were dead. This one's super deep. This one's life-threatening. This one goes all the way into the fascia, the muscle, or the bone. So you burn through your epidermis, your dermis, your subcutaneous tissue, and then on top of that, your muscle and your bone. So this one's very, very deep. Usually these patients are only sensitive to deep pressure only, and these never heal. So diagnosis is going to be dependent on the total body surface area, like how much of the body is being involved. And you usually do the Lund-Browder chart, right? There's a different chart that we use, and I apologize, I don't remember the name, but the Lund-Browder chart is the one that for your exam we think about, right? The rules of 9. So let's go into each one. So 9% is going to be the entire head. So anterior portion of the face is going to be 4.5%, 4.5%. Usually when we think about the torso, 18% is going to be the anterior torso, 18% is going to be the posterior torso. Half of the torso, which is like the chest, would be 9. The lower half, it's going to be another 9. Together, it's going to be 18%. When we think about the arm, it's going to be 9% the entire arm. So the anterior portion is 4.5, posterior portion is 4.5. The entire arm is going to be 9%. The perineum, or the genital area, is going to be 1%. The entire leg is going to be 18%. So the anterior portion is going to be 9%. The back is going to be 9%. And that's usually how you think about these. Make sure you know this, you memorize this, because I can guarantee you're going to get a question on your PANCE, on your end of rotation for this, because this is something that's very highly tested. So really, treatment is going to be depending on how much of the body surface is involved, and then of course what type of burn is it. So usually minor burns, we think about partial thickness burns that are less than 10% TBSA in patients between the ages of 10 to 50, less than 5% under 10, and then over 50. Full thickness is going to be less than 2% TBSA in patient without injury. And the thing about these burns is that, of course, we refer them to the burn center, especially if they're your deep partial thickness and your full thickness burns. These patients get a ticket to go to the burn center, especially also if they're on areas of the hands, if they're on the face, for example, the perineum, right, the feet, or if they're circumferential, right? And what happens with these burns is that I had a patient once that come in and she got burned from like oil, so grease burn, and it was on her lower extremity on her calf. And this one was circumferential, so it went around her entire calf. And this was a deep partial thickness burn. And the thing about circumferential burns, or just burns in general, is that whenever they heal, they can, especially if they're circumferential, they can compromise blood supply. So blood supply going to that area, it's going to become necrotic and the patient can lose their limb. So circumferential burns get a ticket going to the burn center, right? And then especially comorbidities that the patient might have. Are they older? Where are they located? Like we discussed, like on the face, these patients will get referred to us also. What comorbidities do they have? Are the diabetics? Dementia is another one that we got a lot in regards to these patients. So what are the comorbidities? What type of burns? And what's their body surface area? For the ICU, so I was in the step-down unit of the burn unit. So we have our ICU, burn ICU, and then you have your step-down. So any patients that have more than 20% of the body surface area, they would go to the ICU, right? And then you have your step-down is once these patients gotten better from the burn ICU, then you step down to burn unit, and we keep treating these patients' wounds, but they're not as severe as when they came in. They're better. Or usually in the step-down unit, we get patients that have like 5%, 6%, 7%, those circumferential burns, right? Those partial thickness burns, deep partial thickness burns. This is where we would get these patients. So treatment for these patients, if it's a superficial burn, right? Usually with these patients, they'll get something like silver sulfasalazine, usually with these patients. Also, just make sure that we do things like cooling, right? Gentle cleansing, dressing, pain management is a big one because these patients are in a lot of pain, especially your partial thickness burns, right? These are really painful. Why? Because they haven't burned through that nerve yet. And just make sure that we're monitoring these patients for infection. And like I said, these patients get transferred to the burn center. And especially like your full thickness burns and your deep partial thickness burns, these patients need grafts. And what are grafts is, what we would do is that we would get an area of the patient's body that has a lot of skin, for example, the back, and they would go and slice a very thin portion of their skin. And they would do this in the OR, and then they would just stretch that skin out, make it really large, and then they would go and apply that skin on the area. And why do they do that? And why do they get a very, very thin portion of the skin? Is that they do that because that area is going to grow on your back, right? It's going to regrow, right? And then you just put it over the area of your deep partial thickness and your full thickness burns. And it's going to help the patient heal faster. It's going to help prevent the patient from contracting. So contracting is when the skin heals, and especially like if it's an area, for example, like if it's on the wrist, and if the patient has like a deep partial thickness burn and this patient does not get a graft, they're at risk of contracture. So that means that whenever it heals, it's going to heal in a very weird way. So it's going to heal like this. So can you imagine what that's going to do to the range of motion of the patient? They're not going to have good range of motion. And so this is where surgery comes into play. This is where your occupational therapy and physical therapy comes into play in regards with patients, just helping them, ensuring that they are moving their hand. If it's on the lower extremities, ensuring that they walk and they're not in a certain position only because they can develop these contractures. And that's what we're trying to prevent with these patients, is these contractures. So that is for burns. Hopefully it was helpful. I really enjoyed that rotation. Definitely learned a lot. The key for this one, like we said, is just learning if it involves the epidermis, the dermis, the subcutaneous tissue, the muscle. And superficial, like we discussed, is just superficial. It just involves the epidermis. We think about our sunburns. Usually these patients, just give them some topical cream, right? We get into our second degree or our partial thickness burns. We think about our partial thickness burns. The first one, these patients, right, it's going to be very, very painful. Why? Because they still have their nerve that's intact with these patients. And also, it's going to be red, weeping, blanching. And then we have our deep one. This one is where they have damage to the epidermis and the dermis. It's deeper into the dermis. This one's going to be blistering, right? Wet. It can be waxy, dry, patchy, white to red. This one does not blanch with pressure. And then we have our third degree, which is going to be a full thickness. This one's going to be painless because they burned through the entire nerve, right? And it's going to be white, charred even. That's how I've seen it. And make sure that you know your body surface area. So the next one's going to be stasis dermatitis or venous insufficiency. So stasis dermatitis, venous insufficiency, this is going to be an eczematous eruption that occurs in venous insufficiency or stasis and leg edema. It can be acute or chronic. Etiology is going to be smoking and obesity. Usually they have an increased risk for ulcer development, increased risk for peripheral vascular disease, right? On physical exam, you're going to see this itchy red scaly plaque that's going to be weepy. You're going to see these inflammatory papules. They're going to be scaly, crusted erosions, brown pigmentation, petechiae, venous ulcers. And usually the venous ulcers are going to be where? On the medial malleolus. This is something that they really like to test, and how you can differentiate between your peripheral artery disease and any type of venous ulcer is, for me, how I memorized it. And one of my classmates actually came up to this with this, so this is not my credit, it's their credit. Is that venous has an E, venous, medial has a second E. So venous, medial, and these, so since it has venous, it's going to be medial to the malleolus, so venous, VE, and then medial. So usually found on the lower 1/3 of the legs and ankles. This patient can also present with varicose veins. Early signs is usually going to be edema that's going to be better in the morning, hyperpigmentation. Late signs are going to be your lipodermatosclerosis. This is going to limit their ankle movement, venous ulcers, and also porcelain white scars. Chronic stasis dermatitis or venous insufficiency is going to be usually fat necrosis, permanent sclerosis. You're going to see that inverted champagne bottle leg, right? There's going to be edema above, and then below it's going to be very sclerotic. Diagnosis is going to be a Doppler ultrasound. We're going to see incompetent veins and venous occlusions with these patients. And then in regards to treatment, it's just going to be elevation, compression, stocking, so things like your Uniboot wraps, wet compressants for the erosions and ulcers. You can also do high potency topical corticosteroids. Make sure that we're avoiding topical antibiotics. And complications is that the patient can get recurrent ulcers, cellulitis, contact dermatitis, and venous thrombosis. Venous ulcers is going to be the next one. This is where there is skin that's warm. You're going to see erythema, edema, hyperpigmentation. And where is it going to be found? Right on the medial region of the lower leg. It tends to involve or associated with the great saphenous vein. Diagnosis, we're going to make sure that we do a good exam, right? We want to make sure that we get the pulses, capillary refill. We check for neuropathy, those deep tendon reflexes. We do an ABI also. We can do a venous Doppler, and then just measuring the ulcer at every visit. Treatment's going to be elevation, moist dressings like hydrocolloid, topical corticosteroids, compression therapy, except for a patient that has an ABI greater than 0.5, right? Because usually in these patients, um, they're already at risk for losing their limb, and this is very, very severe. And if you do compression stockings, it's going to decrease blood flow to that limb even more. So it's contraindicated usually in these patients. Debridement and just educating the patient right on avoiding any type of topical antibiotic, cleaning the ulcer with saline, and just avoid any type of picking at the ulcer, right? So the next one's going to be arterial ulcers. This is due to peripheral arterial disease. The thing about this one is that the skin's going to appear cold and dry. They're going to have diminished pulses. There's going to be shiny, taut skin, hair loss, worse with elevation, and it's going to usually be found either on the ankles, toes, or heels. Diagnosis, we're going to do an ankle brachial index or your ABI ratio. So it's going to be the systolic ankle over systolic brachial, and usually it's going to be less than 0.8 or less than 0.1. ABI can be sometimes be high in patients with diabetes. And these patients are going to be presenting with that claudication, right? That cramping pain whenever they walk. Treatment for this is going to be ensuring that we refer them to a vascular surgeon because they might need surgery. And the key with this one is that what can prevent these ulcers is just stop smoking cessation, right? Controlling the patient's diabetes, hypertension with statins, hyperlipidemia, weight loss, exercise, and wound care, and putting a patient on an antiplatelet. All right, guys, so the next one's going to be your neuropathic ulcers or your diabetic ulcers. So this tends to occur in areas where the patient puts a lot of pressure, right? So we're thinking about the soles and the bony prominences under the foot, like the metatarsal heads. And the reason why is, remember, as diabetics, what they do is that they really blow out all their nerves. They're pumping all this glucose all over their body, through their vessels, and it's really destroying their nerve cells or their nerves in general. And so that's why these patients are very prone to getting neuropathic ulcers. So some of the risk factors for these are going to be smoking, foot ulcers, peripheral vascular disease, amputation, diabetics, right? Specifically if they don't have a good glycemic control, so control of their glucose, peripheral neuropathy, diabetic neuropathy, visual impairment, like patients that are blind or just have problem with their vision are very prone to getting these neuropathic ulcers. And diagnosis, we're going to do an ABI with these patients. If we have a concern for osteomyelitis, then we'll do an X-ray or an MRI. We also do that monofilament testing for neuropathy. Treatment's usually going to be vascular surgery, wound care. Make sure that we also get endocrinology involved, specifically since a lot of these are associated with diabetes and a lot of these patients have a very poor glucose control. We're going to do moist dressings, and then we want to make sure that we protect the ulcer by doing shoes that are specific for that patient, offloading devices, right? And just prevention, ensuring that we control that patient's glucose, annual foot exam, self-exam, tell the patient to stop smoking, treat their hypertension, their comorbidities, if they're obese, lose weight, treat their hyperlipidemia, put the patient on statins. Next one's going to be urticaria, also known as your hives. These are going to be vascular reactions to the skin that are characterized by wheals surrounded by either a red halo or a flare. Usually the patient's going to have a transient edematous papular or plaque. Usually the etiology is going to be idiopathic, sometimes associated with infections or even reactions to certain foods, right? In addition to that, even certain medications. In children, the most common cause is going to be a viral infection. So this patient is going to be presenting with pruritus, and that's the key, right? Is usually itchiness, and why it's usually due to swelling of the upper dermis. And the key for this one is also going to be those wheals, appearance of those wheals, not like wheels on a car, but wheals, W-H-E-A-L, wheals. They appear within minutes, and they enlarge and they blanch with pressure and they turn white. Diagnosis is going to be clinical. Usually, if it's acute, the patient's going to be presenting with these symptoms for less than 6 weeks. If it's chronic, the patient's going to have these symptoms persistent for more than 6 weeks. We want to make sure that we also assess for anaphylaxis, right? Because anaphylaxis can kill a patient. So ensuring that we look into the back of the throat. Do they have any type of enlargement of the tongue or anything that can possibly be restricting that airflow of the patient. So treatment for these patients is going to be with antihistamines. Um, Usually we can do either first generation or second generation. We tend to try to give second generation, right? Because first generation are associated with making a patient more sleepier, like sedation, versus second generation, they're non-sedating. So specifically those patients that drive a lot, like your truck drivers, then we probably want to consider something like a second generation antihistamine, right? We can also do doxepin, prednisone, especially if the patient's presenting with urticaria, and then on top of that, angioedema. If they're in anaphylaxis, make sure we do our ABCs right. Airway, breathing, circulation. Make sure that we control that airway. If we need to intubate the patient, intubate them, breathing, circulation, and then of course give them epinephrine, IV fluids, and then oxygen, and these patients get a ticket to the hospital. So next one's going to be angioedema. This is a pathology in the deep dermis and subcutaneous tissues. It's most commonly found on the face, but it can, or extremity. This one can last several days. Usually they're going to be presenting with a deep, ill-defined swelling, painful burning, but it's not going to be itchy. If it's on the palms or soles, it can be painful. If it's on the larynx, it can actually cause the patient to asphyxiate, right? Next one's going to be acanthosis nigricans. This one's very commonly tested, so make sure that you know this. So real quick, I'm sorry, going back to angioedema, also think about certain medications that are associated with angioedema, right? We're thinking about usually like our ACE inhibitors that are associated with angioedema. So just make sure you have that in your back of mind also. So acanthosis nigricans, this one's very highly tested, so make sure that you know this one. This is going to be that velvety hyperpigmented plaque on intratriginous areas. How I've also seen it on question stems is that it just looked like it's very dirty, right? And usually when we think about it, it's commonly found in the back of the neck. So some of the causes of this is going to be by far the common one is usually some type of insulin resistance. We think about our diabetics, also very commonly found in your obese patients. It can also be due to certain medications like nicotinic acid, also commonly associated with certain cancers. So like your GI cancers, it's very commonly associated with GI cancers, lung cancers, GU cancers, and lymphoma. But by far out of all of these, GI cancers are commonly associated with acanthosis nigricans. So it's going to appear dirty, like I discussed. Lines are going to be accentuated, hyperkeratotic. This patient can also present with skin tags. And if you don't know what skin tags are, I have a lot of them on my neck. You can see them. I'm actually trying to get rid of them. So they can present with skin tags. And usually it's an insidious onset. Now, if a patient presents with something that we are considering that might be malignant, that it might be associated with, like we discussed, like GI cancer, then it's usually going to be found on the palms, oral mucosa. They're going to have periocular or oral involvement, vermilion border. Usually we think about those trypans, and literally it looks like intestines. And treatment is just make sure that we treat the underlying disorder, right? If they're diabetic, make sure that we get the diabetes under control. If the patient is obese, make sure we get the patient's weight control under control. Usually, the removal is usually more cosmetic, so you can do something like a topical keratolytic, topical or systemic retinoids. But once again, acanthosis nigricans is something that's very highly tested. Velvety hyperpigmented plaques on intratriginous areas. Etiology is going to be hereditary, obesity, and we usually think about diabetes, right? Next one's going to be a lipoma. This is going to be a collection of fat under the skin. If you watch Dr. Pimple Popper, she does a lot of these. And during my surgery rotation, I rotated with a general surgeon, and we did a lot of these. We saw a bunch of them. The common ones we saw were on the back, like near the neck area, and these can be really big. And these are benign, but they are just cosmetically not like they're not nice. They don't look nice, right? They don't look good. So a lot of patients get them removed. I remember like a 17-year-old that she had it on her neck, and it was so bad that it was really affecting her posture. So she went and she got it removed. And these are benign. It's just a collection of fat under the skin. And usually it's familiar, so it's going to be autosomal dominant. They'll have a family history of it. It begins in early adulthood. It's slow growing, and sometimes it can occur in hundreds. Usually the texture is going to be soft, round, lobulated, movable, and that's going to be the key for this one and how you can tell whether it's benign or malignant. And this one's going to be very movable, lobulated, soft, round, and like I said, it's usually found in the trunk and like in the neck portion. Proximal extremities also. And treatment's just surgical removal. You really don't have to remove them because they're benign, but of course it's going to be very cosmetically ugly to the patient, so they want to remove them, or just like it can affect areas like their posture. So next one's going to be photosensitivity. So photosensitivity is usually an abnormal response to sunlight only in body regions that are exposed to the sun, right? And it's usually due to phototoxic medications like antimicrobials, right? NSAIDs also. And with these patients, they can present with acute or chronic symptoms. If it's acute sunburn type, right, they're going to have a rash or urticarial response. If it's chronic, usually it's going to be dermatohiliosis or photoaging. So the next one's going to be dermatohiliosis. This is repeated solar injury over many years. This one's very common. It's usually going to be found in the areas that are exposed, right? So the face, the periorbital areas, the perioral areas. So any area that's exposed to the sun, scalp, especially in your males that are bald, nuchal areas, the lower arms, the dorsum of the hand. And this patient is going to be presenting with a skin lesion, epidermal atrophy, and dermal hypertrophy. They're also going to be presenting with telangiectasias, spotty depigmentation, hyperpigmentation. They're going to have a wrinkled, leathery, prematurely aged cigarette-like. That's how their skin's going to look. Deep furrow-like wrinkling, waxy, papular, yellowish hue, bruising, macular hyperpigmentation, sorrel lentiginous, and comedones. Treatment is just prevent the skin cancers, protective sunblock, change the patient's behavior for the sun, and topical chemotherapy. We also have cherry angiomas. This is a commonly acquired vascular proliferation where there's dilated capillaries, very commonly found in the third and fourth decades of a patient's life, most commonly found in elderly, very commonly found usually on the trunk of the patient. And usually it's asymptomatic. It's more like a cosmetic appearance. They can be black, and sometimes they bleed, they thrombose, or sometimes they even look like melanoma. So usually with these patients, the clinical diagnosis, if we have doubt or if we think that it might be melanoma, then that's when we're going to refer these patients, but usually it's a clinical diagnosis. Treatment is usually cryosurgery. It's not very effective though, so we can do something like electro or laser coagulation. And like I said, this is usually cosmetic. You really don't need to remove these. And then we have telangiectasias. These are going to be these prominent cutaneous blood vessels that can be either physiological or pathological. They're usually dilated capillaries. They can be on the face. They can be anywhere. And usually, like I've seen them like around the nasal folds. All right, guys. So just make sure that you know this. So once again, deep partial thickness. It's going to be what? Perceptive to pressure only, like we discussed. Superficial partial thickness burns, painful to temperature and air. Full thickness, deep pressure only. I'm going over these because these are very, very commonly tested in regards to your burns. So that ends our skin PANCE review. So dermatology PANCE review. I hope this video was helpful. As always, if you have any questions for me, any comments, any feedbacks, or just any future topics that you would like me to discuss in future videos, please comment below. And if I made any mistakes, please let me know so I can correct them below. And that way you guys aren't learning the wrong things, and then I'll edit it. And if you have any cool mnemonics for other students to learn in order to memorize certain medications, to memorize certain skin diseases, please comment below because we all want to make sure that we help each other right to pass the PANCE, or whether you are using this for your didactic year PA school or whether you're using this for your clinical year PA school. As always, take care and I'll talk to you guys later.